So how is Salma? Where is Ruhi?
Ruhi
Sir,
is
Ruhi
also
Ruhi.
with us.
beside me. She is
You
just
can
near
see
to
her.
me.
He can see her. You can go to the side by side view, so you
Yes.
will see everybody.
Hmm. I cannot see everyone in a single plate. That's why I am searching for everybody.
Yeah.
So here we are just the panelists and the speakers. So they are not in the screen actually, but she is sitting beside me.
Oh, oh, oh. Now you are on the platform.
Yes, sir.
Can you see my screen, please?
Yes, please.
Okay. Thank you very much. So, with permission of the President of Bangladesh Glaucoma Society, we are going to start our 11th annual general conference, and it is virtual. You know that the whole world is pandemic from the COVID, and many of us are infected. Many of us are now better. So let us hope this pandemic will go soon from us and will be vaccinated soon. Ladies and gentlemen, good morning to all of you, and some of our friends who are joining from West, good evening to you all. This morning, we have the session Surgical Update on Glaucoma 2020 Perspective. And we are very happy that we have very famous faculties, speakers, Dr. Gabo Lascano from Mexico, Dr. David Richardson from USA, Dr. S.S. Pandab from India, and Dr. Sheikh Mohammed Hussain from locally from Bangladesh. We're also very happy that we have very eminent glaucoma specialist as our panelist, Professor Sheikh Ahmed Mannap. He is the past president and advisor of Bangladesh Glaucoma Society. Professor Mannap is the managing director, Harun Eye Foundation and Hospital, and he is the former head of ophthalmology in the Bardem Hospital in Dhaka. We have panelist, our president, Bangladesh Glaucoma Society, Dr. M.D. Mizanur Rahman. He is also professor and head, Department of Ophthalmology, Bangladesh Medical College Hospital. And he is also president of the International Society of Manual SICS Bangladesh chapter. We have our dynamic Secretary General, Dr. Salma Parveen, and she's also our panelist. She's also associate professor and head, Department of Ophthalmology, Green Life Medical College and Hospital. She is also consultant, Bangladesh Eye Hospital. We have our friend, Dr. Iftekhar Muhammad Munir. He is the treasurer, Bangladesh Glaucoma Society. He is head of Glaucoma Division of our National Institute of Ophthalmology in Dhaka. He is also consultant, Bangladesh Eye Hospital in Bangladesh. We are supposed to have Dr. Chandrima Pal. For some reason, she could not join with us. And I am Dr. Nazrul Islam. I work in the Bangladesh Eye Hospital as chairman of glaucoma faculty, and I was also president of Bangladesh Glaucoma Society. And this morning, I'm going to moderate the session. So without delay, we welcome our friend, Dr. Gabriel Lascano Gomez, and he says he is Gabo Lascano. And Dr. Gabo Lascano is the associate professor in the APEC Hospital in Mexico City. He had done his residency and fellowship from the APEC Hospital in Mexico. He is the visiting international professor in the Colorado University Hospital. And Dr. Gabo is going to talk on the ab interno-trabeculotomy with Kahuk dual blade or KDB. Welcome, Dr. Gabo Lascano. The floor is for you. Please have your presentation. Dr. Gabo Lascano.
Thank you, Dr. Nazrul. I'm going to share my screen. And first of all, I want to thank you all for the invitation. Of course, all the committee, all the panelists. I'm very happy to be here with you at the distance, but very close from my heart. So we're going to start talking about the ab internal trabeculotomy using the KDB or Kahoot dual blade. And first of all, I want to introduce my country. Mexico is just south of the United States, for those that don't know where Mexico is. And I live pretty in the center of Mexico. We have the only mountain with snow in the whole country that actually is not a mountain, it's a volcano. And you can see that it's active right now. So this is where we live. And of course, we wait you for next courses. These are my disclosures. And I want to start with a company video to show you how the design of the KDB is. This is the tip of the device. The tip is very useful to penetrate the trabecular meshwork and the internal wall of Schlemm's canal. And you can see that there are two blades, the dual blade system, that they help us, to cut and take out from the eye all the tissue that we are supposed to cut. This is a video I now use or prefer to do the surgery for cataract surgery at the same time because I have a better view. And using a gonio prism and the KDB, we cut inside the canal. We pierce the trabecular meshwork and the internal wall of Schlemm's. We go to the right, and then after finishing the first cut, we go to the other side to complete an in 90 to 100 degrees surgery. We can see there that there's always some blood reflux from the collector channels. At the end, sometimes we can have the trabecular meshwork, as you can see that image, especially for research, it's very useful. There's another video showing how we insert the KDB. In this case, we're going from left to the center, to cut and to extract trabecular meshwork and Schlemm's canal wall. So in this surgery, we're going first from left to center, then right to center to join the cut at the center. And then afterwards, using microforceps, we can take out the tissue as you're seeing in this video. Well, what we want to see at the postoperative gonioscopy is something like this. We want to see how the trabecular meshwork and the angle sees like a whitening of the surgical site. That means that we did an eye surgery. When we get this, I'm gonna show you the first multi-center trial that we did. We collaborated with some US doctors and Mexico City, of course. And what we got from this surgery were IOPs in the rank of between 12 and 17. You can see that we included patients with IOP in the high teens. However, we got a nice reduction, 5 millimeters in average after surgery after 1 year. So this is what we get with all the canal surgeries. This is what canal gives us. It's always IOPs between 12 and 17, and of course a good number, 64% of the patients could suspend one medication. So for all the devices that work at the canal, let's say trabectom, KDB, GAT, iStent, what we're going to get are IOPs between 12 and 17. In this paper, where we do surgery on severe or refractory glaucoma, we had a very good response in IOP. We got a little bit higher IOPs, but in the same rank, between 12 and 17. So take that in mind when you plan to do a canal surgery. You will get those IOPs between 12 and 17 again, with the use of at least 1 or 2 medications. Well, this is what we want to do, and this is what we expect to have at the postoperative. But there are some surprises sometimes you cannot complete the treatment, and this is because of the blood reflux that you get from the surgery that doesn't allow you to continue the surgery. Sometimes these incomplete treatments give you good surprises, even though these surgical incisions are small. Sometimes they get good IOP reductions. For example, in this case, you can see at the red arrow that sometimes you cannot get out or take out, sorry, the tissue. And some other doctors have asked me if the tissue covers again the surgical site, and this is not correct. The trabecular meshwork strip that you can see at the red arrow, tends to degrade inside the anterior chamber, so it doesn't cover again the surgical site. This is important to know, especially in a hospital like mine, where there are a lot of residents and fellows. You can have very bad or serious complications, like in this picture, you can see a cyclodialysis that, of course, needs a repair. Or sometimes you can get this. This is a personal case, and this was, I made a lot of mistakes in this surgery. First of all, this patient was a doctor at the same hospital as me. He was on anticoagulants, and I suppose that he, being a doctor, was going to tell me that he was on anticoagulants. I didn't ask him, and I touched the iris root, and this is what I got. After washing the blood from the anterior chamber, we got this macular edema. However, it solved 1 or 2 months after the surgery. Everything went perfect, but with these cases, you cannot sleep until you get good results. So this is something that you have to take in mind. This is minimal invasive glaucoma surgery, but you can have these awful complications. Some more complications as a Descemet's tear, for example, a PAS here with the OCT, it could be treated easily with pilocarpine or argon iridoplasty. You always get peripheral anterior synechia. That's what I prefer to use pilocarpine the first 2 weeks after surgery, so to avoid a lot of PAS at the postoperative gonioscopy. So this is the best slide, in my opinion, is this one. As long as you stay in the green square, you're going to get good results from this surgery. Let's say that you have patients with intraocular lens, pseudophakic, that you are going to do phaco at the same time than a KDB, with a mild to moderate glaucoma, with an IOP below 25, and with open angle glaucoma, of course, that you will get very good results. Understanding that good results are IOPs between 12 and 17 on 1 or 2 medications. And if you go to the yellow zone or to the red zone, let's say that patients with higher IOP than 25, with angle closure glaucoma, refractory glaucoma, and moderate to severe glaucoma, where you need IOPs below 12 or 10, this is not a good option. You're not going to get those results in these patients. So if you choose the right patient and you do the things correct, you're going to get good results with this technique. And this is the presentation, my first talk. Thank you. And please feel free to ask any questions that you think are convenient.
Okay, thank you very much, Dr. Gabo Lascano. Thank you very much for a wonderful presentation on KDB. I think KDB is one of the popularized tool as MIGS for the treatment of glaucoma, open angle glaucoma. And it's very high demanding blade. And we asked the blade from USA, from the company, they said it is not available. It's so much demandable in USA and other countries. So may I request Dr. S.S. Pandab to have a comment on Dr. Gabo Lascano's presentation, and if you have any question. Dr. Pandab, are you here? Dr. S.S. Pandab.
Sir, maybe Dr. Panda is disconnected from the panel somehow.
Okay. So any of the panelists have any experience of KDB?
I was disconnected
Yeah, he has
actually.
come.
Oh,
Yes.
sorry. No problem. Welcome again. No problem.
Also the
Dr. Pandab, we heard the nice presentation from Gabo
I
Lascano.
could gather that was wonderful, and I could see, very beautiful, presentation, and some complication also. It has some full chamber high fever, and I was actually thinking that maybe this is a procedure which could give you a lot of high fever at times. So how often do you get into trouble, Dr. Gabo, with this procedure?
Well, in these days, not very often. These images are from the group of residents, fellows, and some of professors that when we started doing this surgery, we didn't have a lot of experience with angle surgery. So this is why my presentation is aimed to tell you that you have to prepare, you have to practice before going into the private practice and doing surgery on your patients, because even though they call these procedures mixed minimal invasive glaucoma surgery, sometimes they are not as minimally invasive as they say. So it's better to prepare, and if you do things correct, everything's going to be all right.
Yeah, I think the amount of tissue you cut is less, but I think the procedure itself is a full surgical procedure. So it goes with all the precautions that you have to take, and also, has its share of complications. So that's true. And what is your experience with IOP reduction after this procedure, and how many clock hours you generally do?
Well, we usually treat, between 90 and 100 degrees is what the gonioprims allows you to see at the canal. And this is something tricky that I always say to doctors, because I collaborated with, the first trials and still doing it with the KDB. And, when somebody says that this device gives you 50% of reduction or 20% or 15%, all depends on the baseline IOP. As you could see, the first multi-center trial, we included patients with IOPs below 20, and we got, what we expected, IOPs between 12 and 17. And also for patients above 20 but below 25, you can have that reduction. So the percent of reduction depends on the baseline IOP. But for patients with IOP higher than 25 or 30, you can have a good reduction, but in the terms of the 20s. So it's better not to do surgery in these patients, because if you do that, you're going to have a high IOPs, and they will still need a trabeculectomy or an AMED or something.
Thank you, Dr. Gabo. I have a question that if the patient having cataract, so, and there is a question from Dr. Ishtiakanor actually, if you have you need to do phaco and KDB together, can you do together or do separately? Which one first? If you want to do cataract surgery, phaco, you can get it together. So if any patient having not cataract, only KDB, can you do that? Only KDB?
Yeah, I've done it in 3 or 4 patients. The patients with steroid-induced glaucoma, for example, with no cataract, and I haven't had good results. So in the phakic patients with only KDB as a standalone procedure, you don't get very good reduction. It's better to take out the cataract, of course.
Okay. So any question from any panelist?
And just let
any
me
comment
finish
from
this.
Other panelists, please. And any experience of KDB from other? Dr. Pandab, do you have experience of KDB surgery?
No, you're not doing with the Cahuck's blade.
You are not doing. Same. Yeah. Same in Bangladesh. We do not have the blade available here, but fortunately, one of our friends from USA, he brought 5 blades for us, and I had the experience of doing 5 surgery. And out of 5, all surgery had hyphema. And it is really difficult to see the angle. It is really needs learning curve. And fortunately, 3 patients did well and pressure come down, and 2 patients I needed to do trabeculectomy later on. So this is my little experience of KDB surgery, getting blade from one of my friends. So otherwise, any other panelists had done any, Dr.
I
Sheikh
have
Mohammed
a,
Hussain, any experience?
We are doing.
Professor Munir, Professor Munir, please.
I have a question to Dr. Gabo regarding your KDB location. Which quadrant is ideal? You think better? If it is superior, inferior, or other quadrant? Which quadrant is better for KDB surgery? Can you hear me?
Okay, yeah, well, we usually do, yeah, I can hear you well.
Which quadrant? 360 degree, it is inferior quadrant or superior quadrant? Which quadrant ideal site for KDB surgery? For intern or trabeculotomy?
Yeah,
I
we
think nasal
usually do
side,
the
Dr.
nasal
Munir.
quadrant.
Nasal, because temporal incision, usually we give temporal incision, and we do the KDB surgery in the nasal angle. Gabo, right? All right. Do you agree?
Yeah, because
We do the
when
nasal
you,
angle first. Yeah.
when you do surgery, yeah, you're right.
Dr. Gabo, I have a question for you. I mean, on the doctor which you did the surgery, and unfortunately he was on blood thinner and he had a hyphema. What was the pathogenesis over there when the patient had this macular edema following hyphema? Can you just explain? You heard what?
I can't hear you very well. Can you repeat the question, please?
My question to you is that on the patient which you did the surgery, patient unfortunately had the hyphema, and subsequently he developed macular edema also. So what is the pathogenesis over here having this macular edema?
Sorry, my connection, I think it's not very good. Well,
Okay.
From what I understood is that the patient with macular edema,
Yeah,
is that correct?
Following hyphema, on that particular patient, you did the surgery on the doctor, your colleague.
Yeah, well, the mistakes there were many. First of all, he was on anticoagulants. I didn't stop the anticoagulants. We used methyl cellulose at the beginning for the surgery.
Methyl cellulose, yeah.
So yeah, so you sometimes the cellulose disperse like a dispersive viscoelastic, and you lose view. So I cut it, the iris root. So we got a lot of blood, and we washed the anterior chamber 3 times. Because of the inflammation, I suppose, of those procedures, we got macular edema. So we injected steroids, to reduce the macular edema. And finally, we got a 20/40 visual acuity after 3 months. Fortunately for him, his visual acuity was 20/150 before surgery. So with a 20/40, he was very happy.
Okay, yeah, thank you.
Thank you very much, all the speakers and panelists. Thank you very much. It was a great discussion. Probably we'll have some more time after the session of all speakers. So now let's go to the next speaker, Dr. David Richardson. Already I mentioned, unfortunately, he became COVID positive few days back, but he was all right. He has a very little symptom. He told me that he will join to us. But yesterday night, in the midnight, he told me that he's having breathing problems, so probably he will not going to join. So we pray for him that he can be a quick, very early recovery from the COVID infection. And we know that he is working in this San Gabriel and San Marino in California, and he is a very good teacher. He's a trainer of the surgeon and chief medical officer in the iFlow. He was supposed to speak on why should we respect and protect the trabecular meshwork. This subject is actually on the other hand of Dr. Gabo. It is opposite side. that he does not want to destroy the trabecular meshwork by Cahook dual blade or by goniotomy. That is his procedure, and he wants to talk on the time like that. So today he permitted to show one of his video to you all. I'm going to there. This is the email yesterday midnight. He sent to me that he's having 93% oxygen saturation, unfortunately, so he will not be able to join. So he is Dr. David
Hello,
Richardson.
I'm Dr. David Richardson.
Can you hear
I'm
the
a
sound?
cataract and glaucoma surgeon here in sunny Southern California, which you can see.
Yes,
Can
sir.
you hear the
Very
sound?
clear, sir. The sound is very
Okay,
clear.
okay.
So I actually elected not to drive and video today because here in California, drivers don't know how to drive in the rain. Now, say what you will about Boston drivers, but when I was back there for medical school, they knew how to drive in the rain. So anyway, today I would like to talk about something that's getting a lot of traction in the ophthalmic community. And so I would expect patients with glaucoma to be offered a minimally invasive glaucoma surgery that goes by the name of either goniotomy or trabeculotomy. Now, there are two that are getting quite a bit of interest right now. One is gonioscopy-assisted transluminal trabeculotomy, or GATT for short, and the other is Cahook dual blade goniotomy. Now, what these both have in common is that a small incision is made in the cornea through which either an instrument, the Cahook dual blade, is used to tear open the trabecular meshwork, or a suture or catheter is threaded into the Schlemm's canal and then torn through the trabecular meshwork. So they both are trabecular meshwork destructive. They're both quick, they reimburse well, and so you know, we'll talk about whether they work and some of the issues involved. Now, the interesting thing is that these procedures are actually based on trabeculotomy, goniotomy, procedures that have been around for 40 plus years. Now, the question, of course, comes up, well, if they've been around for this long, why is this kind of a new interest? Well, they've been used in pediatrics for this whole time with a fair amount of success. But in adults, after some initial excitement 40 plus years ago, it kind of fell out of favor in adults because the effect did not seem to last. And the thought was that where the suture pulled through, or the instrument pulled through the trabecular meshwork, which is the drainage grate in the eye, that's generally how it's thought of, that it left little leaflets that could kind of scar down over time. So the effect of goniotomy or trabeculotomy in adults did not work well long term. In kids, there's actually a membrane that is torn through, and that membrane does not seem to grow back. So that's why it seems to work in kids, whereas it doesn't work so well in adults. Now, a few years ago, in 2005, Barvelt and colleagues patented a device called the trabectome. And the purpose of the trabectome was to essentially remove the trabecular meshwork without there being any residual leaflets. So it prevented the opening from scarring down, allowing fluid to get directly into the drainage canal, which is called Schlemm's canal, and then out through what are called the collector channels into the bloodstream. Now, the problem was that the trabectome was a very expensive instrument. I never priced one, but I heard they were around $50,000, and there weren't too many physicians or surgery centers that were interested in paying that upfront cost. Oh, and then the handpiece itself was had to be paid for every single time. So trabectome, for that reason, as well as some others, such as it just didn't seem to work all that well. I mean, it would bring the pressures on average into the high teens, which is okay for somebody who has mild to moderate glaucoma, but it's not really of benefit to anyone with more severe glaucoma. So that fell out of favor. Then recently, the Cahook dual blade came out, which is essentially a single-use version of the trabectome. So there's no upfront investment, and it removes the trabecular meshwork without leaving any leaflets. So that has gained quite a bit of traction as well. The most interesting thing I find in terms of the recent interest in goniotomy, trabeculotomy, is the gonioscopy-assisted transluminal trabeculotomy. This is essentially the same thing that was done 40 plus years ago. So why is there this excitement now? It involves creating a small incision in the cornea, threading a suture through the trabecular meshwork into the canal, and then ripping it through the canal, very similar to what was done before. There are a couple of reasons why I think that there's interest in it. MIGS, minimally invasive glaucoma surgery, surgery in the angle through small incision, is really exciting right now in the glaucoma treatment community. And pretty much anything that you can do in the angle under a gonioprism and the microscope is of interest. So it is easier to perform this procedure using this gonioscopic approach than it used to be from the outside of the eye, from the sclera. So that's part of it. It's a quick surgery. It reimburses really well when you break it down by the number of minutes it takes and the ease of doing it, and the limited post-operative risk and complications. And early on, it does seem to work. So the early results look pretty good, but of course they looked pretty good 40 plus years ago. So it's probably not going to last that long. We'll see. But there's still the issue of those leaflets sealing down. So it's interesting to me that we've got in ophthalmology, at least among ophthalmic surgeons, kind of this collective amnesia of this procedure not working well in adults 40 plus years ago, but we're all seem to be interested in doing it again now for the reasons I just mentioned. So one might say, well, so what? If you can get a year or so of benefit from a simple, easy procedure that's reimbursed by most insurances, so that's also important from the patient's perspective, why not do it? Why not just rip through the trabecular meshwork? Well, for the same reasons that the trabectome was developed and the Cook dual blade, there's a couple, but there's actually something more involved. It turns out that the trabecular meshwork, what we traditionally think of as just kind of a drainage grate through which fluid motion is restricted, and it is known that there's strong evidence that the majority of patients with open angle glaucoma, that is where the restriction to flow is, in the trabecular meshwork. So it makes sense to remove the trabecular meshwork, remove that restriction to flow. The problem is that we're discovering that the trabecular meshwork is not just a simple grate. The work of Dr. Murray Johnstone has shown elegantly through videos that you can see on YouTube. There's actually a pulsatile flow of the trabecular meshwork that is in sync with the cardiac cycle. So you can actually see the trabecular meshwork pushing fluid out of Schlemm's canal. The trabecular meshwork is a pump. So if you rip the trabecular meshwork out, you've lost that pumping mechanism, and now you're hoping that just through passive flow that you'll get the same kind of flow out of the system. So that's an assumption that needs to be looked into a bit further. You know, will we still long term, after ripping out this pump mechanism, still get long-term flow? And again, the early studies done decades ago suggest probably not after goniotomy or trabeculotomy. But there's more. There are other studies that have shown that in and around the trabecular meshwork and Schlemm's canal, there are actually mechanosensory regulators or sensors. So there are microscopic, at the molecular level, proteins that act as strain and stress gauges, and then can have a feedback. So when they detect certain types of strain or stress, they up or down regulate the flow out of the canal and through the trabecular meshwork. So if you don't have the trabecular meshwork and you just have an open system, there'd be no strain or stress, nothing to detect, nothing to up or down regulate. So we're losing that when we destroy the trabecular meshwork. But then there's also something that's quite practical, regardless of what the laboratory studies show in terms of the function of the trabecular meshwork. There is now a new class of medications, the ROCK inhibitors or the ROCK-NET inhibitors, one of which was just approved by the FDA, which is Ropressa. The generic name is Notarducil, and that works at the trabecular meshwork. So if you've destroyed or ripped or torn out the trabecular meshwork, there's nothing for this class of medications to work on. And Ropressa is just the first of what will likely be half a dozen medications that use this or similar mechanisms. So from my perspective, I don't see any reason to remove or destroy the trabecular meshwork when I may need to use that in prescribing a class of medications for my patients. So although I understand why other surgeons are excited about goniotomy, trabeculotomy in the form of either Cohook dual blade or GATT, I personally don't recommend these surgical treatments early on. I prefer trabecular meshwork sparing procedures such as canaloplasty, either the ab externo approach from the outside of the eye or the ab interno approach, which is called ABIC. I generally use the iTrack microcatheter because it has a lit tip that really allows you to see where it's going very elegantly. In any case, I will prefer canaloplasty or say a hydrous shunt to actually shunt fluid into the canal before I would consider removing or destroying the canal. There are times when that procedure does make sense because the trabecular meshwork sparing procedures have failed. And that the next procedure we might be looking at would be a trabeculectomy or glaucoma drainage device. And those have quite a few potential risks and side effects, which I've described elsewhere on my websites. And have a great day.
I would like to thank Dr. David Richardson, and we pray for his early recovery from COVID-19. And in his video, we have seen that he is not in favor of destroying the trabecular meshwork. And he has shown the KDB trabeculotomy is destroying the trabecular meshwork. And TM is very important for the cardiac cycle rhythm, for the regulation of the aqueous flow. So, and many medicine like ROCK inhibitor, the Ropressa, that is also working the trabecular meshwork. So if you destroy the trabecular meshwork, it will not work. So at last he told that, of course, you can do it, the GATT or the KDB at the end, not in the beginning. I think that is his opinion. So it was really a good subject. I liked it because most of the people we are going to GATT and KDB, but in his opinion, should not be fast. He said it should be the last, not the first. Anyway, we thank also Dr. David Richardson. Hopefully he will join us sometime in future. Now, may I request Professor Sheikh Ahmed Mannaf to have a comment on this presentation, on his opinion. Professor Mannaf?
Yes, thank you very much for giving me the opportunity. I thought that because presenter is not here, only the video, I do not have to comment on this presentation. But still then, I am very much agreed with his opinion that the intraocular surgery like goniotomy or Cohook blade or any other procedure he doesn't like. I also doesn't like. I don't like also. But I disagree with this presentation that if I will do the operation leaving the trabecular meshwork, that means without any peripheral iridectomy. So peripheral synechia at that point would be very common especially in case of angle closure glaucoma or a patient having a narrow angle glaucoma. So in that case, this sorts of surgery, leaving the trabecular meshwork, will not be successful. So this case should be selective. In this case, we will go for the trabeculectomy, leaving the meshwork, and in this case, we will go for trabeculectomy with iridectomy. So the case should be divided. Then the complication would be less, like peripheral synechia, as well as failure of the cases, like trabeculectomy. And he was talking that he will first do that. If fails, then he will go for trabeculectomy. If fails, then he will go for glaucoma bulb. So he can have lot of procedures for the patients of that country. But in Bangladesh, as because we are running with money constraint, that's why we like only one surgery for one patient, and patient will not go for several sittings. That's why we prefer trabeculectomy with peripheral iridectomy, which is very much successful for every type of glaucoma patients. That's why I sometimes agree with him in some points and disagree with him in some other points. Thank you very much.
Thank you, Professor Sheikh Manna, for your nice comment and important suggestion. And we're not going to further discussion on this subject. Now let me welcome our next speaker, Dr. Surinder Pandab. He's a very good friend of mine, and we meet each other in different conferences. Always we meet in India and other parts. And Dr. Pandab is the current president of the Glaucoma Society of India. Welcome and congratulations, Dr. Pandab. And he is the professor of ophthalmology, glaucoma service in the Advanced Eye Center in PGI Medical Education and Research, Chandigarh, which is a very prestigious institute in India. And Dr. Pandab will speak tubes in secondary glaucoma. Welcome, Dr. Pandab, for a presentation.
Thank you, Dr. Nazrul Islam. I'll share my presentation. Can you see my slides now? Is my slide visible?
Yes, visible.
Okay. Actually, I just have changed my computer because there's some problem with the connectivity. So I suspect that some of the videos may have trouble, but let's hope it goes all well. Secondary glaucoma and the tubes. The secondary glaucoma, we know, they're high pressure glaucoma mostly, and most of them can be managed with medicines, but there are some situations, where the medicines don't work, and these are the eyes where the ordinary glaucoma procedure like trabeculectomy or the MIGS are probably out of question in this situation where the situations are quite complex, and usually we have like situations like NVG, the uveitis, post-penetrating keratoplasty, and post-retinal detachment surgery. You had a buccal, pars plana silicone oil. And many of these cases, the anterior segment is actually distorted, anatomy is distorted because of trauma or repeated surgeries or inflammation, that the usual procedure, glaucoma procedure, are not actually a good option here. So in this situation, we actually need some kind of a tube. We have a number of tubes available, essentially valved and non-valved. In India, Ahmed, which is a valve device, is easily available and we have been using for some time. And we also have a non-valve device in Aquis, Orolab Aquis drainage implant, ADI, which is made in India and is actually is a cheaper version of BioVac implant. So this is one example. This video probably will not play. This, you can see that this 50 years old male patient with the 6/9 vision, but IOP is 40 millimeters of mercury with maximum that we can give him in terms of anti-glaucoma medicines. So here we did a primary surgery, tube surgery. Now, as you can see, there is actually a staphyloma there and in the superior half, and there's no place where you could actually put you could do a trabeculectomy or any glaucoma filtering procedure here. However, this video is not playing, so I won't be able to show you. But what essentially happens is that the conjunctiva and the tunnel capsule are reasonably okay over it, and they can be reflected back. And as you go beyond the limits of the staphyloma, there's a healthy sclera where you can put the tube and insert the fix the plate and insert the tube into the anterior chamber. Another situation is a post-pars-plana vitrectomy, silicone oil, and those complex situations where this is 26-year-old male, high myope with history of retinal detachment, both eyes operated multiple times actually, and now the vision is 3/60 and the pressure is 22 millimeters of mercury with all anti-glaucoma medicines. So here the silicone oil was removed and there's a buccal there, so we could, you can see the conjunctiva is kind of scarred there, but we can still, you can see the buccal is visible now. There's a band in that area. So you need a good dissection here to make sure that all the adhesions are broken and both the muscle, the superior rectus and the lateral rectus muscles are identified. And this is a ADI, which is more or less like a beveled implant, which is available in the West. So the one wing of the ADI actually goes, it has extension to the side. So one under the muscle, so one on the superior rectus, one on the lateral rectus muscle, and then suture the plate to the sclera. I use the Dacron suture, which is used by retinal surgeons. Most importantly, but this is a non-valve device, so the tube must be occluded, and that can be done by a 6-0 Vicus suture, and then with a long tunnel, 24G needle tunnel, you can actually pass this into the anterior chamber, and the tube is in the anterior chamber. Because this is we have occluded the tube, so it's better to make a small slit in the tube before you close, so that there's no, some control of IOP in the immediate post-operative period. Otherwise, the pressure could go up. This surgery was done like 15 years ago. Actually, you can see this is the only eye of the patient. He was involved in a 40-year-old male, was involved in a road traffic accident, and one eye lost. And this is the better eye of the patient. Has undergone multiple procedures, and you can see there's a macular scar also, but there is a CY60 vision in this eye, which is actually workable. So we needed extensive dissection. At that time, we didn't have ADI with us, so I used, especially bought a, this beveled implant for him. And that was, the buccal was, because it's a large buccal, so I had to go a little behind the buccal to suture the implant. This is a large implant, so sometimes it could be difficult to position behind a buccal, but luckily we could do in these patients. And because now the conjunctiva was very scarred over this, so I was worried about the exposure. So I had to cut a little bit of buccal, create a tunnel underneath and pass the tube actually through that tunnel so that, it doesn't project, cause pressure on the overlying tissues. And I use this, again, the tube has to be ligated, but I use a stent ligator. I use a stent along with this. So this actually gives me a little handle in the post-operative period if I want to release the pressure early. And I made a partial thickness screw flap here and then went behind the iris to put this tube into the posterior chamber through the sulcus. Basically, you could put it into the pars-plana also in this patient because it's a vitrectomized eye, but I put in the through the sulcus, which is behind the iris and well away from the cornea, and just to be sure that this tissue doesn't give way later on, I had to put a skilled patch graft before I closed. So this surgery was challenging this patient, but I think the post-operative period, if you look at, this is 10 years after the surgery was done, and the patient has maintained a vision of 3/60. This is the only eye and has an ambulatory vision in this eye, and the pressure is 18-20 millimeters of mercury about, after on 2 anti-glaucoma medicines. So the question is how well glaucoma drainage devices do, following vitrectomy and such situations. So I looked at our data, recently, and this is going to be published in the coming Journal of Glaucoma. So we had 78 patients, and all those patients where AGV was done because we mostly have been doing AGV more. Most of these patients had either trauma or rhegmatogenous retinal detachment. 60% of our patients actually belong to these two categories, and remaining were the others. We had a follow-up for about 6 years on an average, but minimum 24 months minimum. If you look at the, the overall results in the post-PPV eyes with AGV, the cumulative probability of success is quite high in these eyes. I mean, they look hopeless eyes, but I think at 92% in 2 years and 80% at 5 years and 74% probability of success 10 years is quite gratifying, in fact. But this is not kind of a complete success in the sense that most of these medicines, they needed, anti-glaucoma medicine to keep their pressures, within the desired limit in the post-operative period. And as you can see, there was a significant drop in IOP as well as in the number of anti-glaucoma medicine that we had to use post-operatively to control pressure, right up to last follow-up. This is another, sometime if the tissue is not, if you have a large buccal there, there may not be enough space to actually put the tube. So this is a 37-year-old male patient who had a trauma 7 years back and multiple procedures were done again. He had a large buccal and we thought that, putting a implant may not be, there may not be enough space for the implant. So in this situation, what we did was that you carefully dissect that area, dissect in a way so that you identify the buccal, but do not destroy the capsule that forms around the buccal, because we can use this capsule as a reservoir to drain the fluid. So what we do is that we take a silicone tube and create some fenestrations on the silicone tube on the side. So this is just basically to create some holes in the silicone tube, and then you can give a little bevel to this and create an opening with 24 gauge needle into that capsule, inflate the capsule a little bit with viscoelastic, and then we can insert the tube through that opening into that reservoir around the buccal, and then make sure that you fix the tube so that it doesn't move. This is a 6-0 Vicryl suture, but nowadays I prefer a non-absorbable suture because sometimes after the suture gets absorbed, the tube can move. And the rest of the procedure is actually very similar to any other GDT, that you just insert the tube in the anterior chamber, and you can see at about 3 weeks, the pressure is pretty good. And this pressure maintained a good pressure to at least 6-7 months. And after that, we had to add anti-glaucoma medicines for this patient also. Other situation is the post-PK glaucoma. And again, the incidence varies depending on the, what exactly was the indication. But overall pooled incidence is about 21%, 21.5% in these patients. It's very important to control glaucoma in these patients because it's not only a danger to the optic nerve, but also to the graft, and the graft failure is high in these patients. So there's a double problem if the pressure remains high. So what we did was we looked at our data, and we have been doing putting tubes into these eyes for many years now. And so we looked at the data, 5 years data between 2013 and 2018. This has been published last year in ophthalmology glaucoma. We had 57 eyes of 55 patients, mostly they were males. And we divided them in 2 groups. By that time, we were using AGV as well as ADI. And so majority of our patients were, of course, ADI, 2/3 of them. So the procedure is like, the standard procedure that you fix the plate to the sclera, say about 10 millimeters, 8 to 10 millimeters from the limbus. I prefer using this Dacron suture because this is kind of doesn't, if the needle is very good, actually a strong suture, it holds well. And the needle is a spatulated needle, which is specially designed to pass through to the sclera. And retina surgeon actually use it for placing buccal. So then you adjust the tube length and create a tunnel which is at least 2.5 or 3 millimeters length, and you can go into the anterior chamber. Make sure that you are away from the cornea. If the space is less, then you can actually go behind the iris into the sulcus as well. As many times I do that. And once that is done, you cover the anterior part of the tube up to 5 millimeters at least with the scleral patch graft, because that's the area where tube extrusions and then can happen. So secure that area, protect it well, and then you wrap the tenon and conjunctiva over that graft. So make sure that the no tenon is left behind and the whole thing is covered nicely. And with this procedure, we could see that even in post-PK glaucoma, if you look at the IOP control in the post-operative period, this is a short-term controls up to 6 months. You can see that RD as well as A. We wanted to look actually if there's any difference in these two valves, but there's no difference. I think both the valves, they work very well. And you can see there is significant depression, lowering IOP over a period of time. And if you look at the survival at 6 months, I think it's pretty good for both of these implants, is somewhere around 85% for both of these. So to summarize, tubes are useful in complex and sometimes desperate situations which secondary glaucoma presents to us. Modification would be required in that technique depending on the situation at hand and the individual needs. But overall, the results are quite gratifying, and one can save control IOP in these patients and save their functional vision in these patients. Thank you very much once again, Bangladesh Ophthalmology Society, for giving this opportunity, and Dr. Nazrul Islam particularly for the invitation. And we do meet at conferences and hope to, see many.
Thank you, Dr. Thank you, Dr. Pandav, for your brilliant presentation. And actually, you have shown use of tubes in very difficult situation, especially post-BR surgery, post-belt buckle surgery is really, really difficult. So before going to, before panelists, may I ask one question to you?
Yes,
that
sure.
if you have this kind of very difficult patient, need to decrease the IOP, will you go for the primary tube, or you will try a trabeculectomy first, and then you will go to the tube? What is your practice?
Some of these we go straight for primary tube, like if you have uveitis or neovascular disease.
Can you stop share, please? Stop share.
Thank you. Stop.
In the up, there is a stop share.
Is it stop?
In the upper part of your computer, you'll see stop share.
Oh, okay, I can see it. Thanks. Okay.
Okay, no problem. Yeah.
Okay, so sometimes I do put a primary tube also, especially if a neovascular disease or angle closure or this
Yes.
uveitis.
Yes. Yes.
But these are the situations like many of these cases you have post-vitrectomy or post-PK. Even post-PK, I put primary tube.
Primary tube, yeah.
But if there's a lot of scarring, and most of these patients, actually there's a lot of scarring, they have already undergone some procedures, and the TRAV is technically also difficult and also has a higher failure rate. So most of these procedures, you'll go for a, straight for a tube.
Primary tube. Thank you very much. Now, can I request Dr. Salma Parveen to have a comment on this brilliant presentation?
Thank you, sir, for asking me to put in comment on Pandav sir's presentation. This is excellent, sir. You have done an excellent presentation. All your surgeries are really good. I really thank it for you. So my question is that which secondary glaucoma you actually see these tubes are more successful? In case of PPB with silicon oil filled eye, or post-PK or uveitic glaucoma, which one is best in your hand, in your experience? What do you say?
Depending on actually how much is the tissue has already been manipulated, that would decide. I mean, all secondary glaucomas won't need tubes. Like if you have a, like you have a pseudo exfoliation glaucoma, is kind of open angle glaucoma. You don't need a tube. That I think that the drugs and the trabeculectomy and the usual procedures will be all right. But these are the situations where the trabeculectomy or the conventional surgery doesn't do very well. And typically the neovascular disease and uveitis, I would say, but even in uveitis, I would try a filtering surgery first if the uveitis is quiet and there's no active inflammation and the anterior segment is not distorted. So if it's possible to do trabeculectomy in a quiet eye after controlling uveitis, I would still do a trabeculectomy first before I do a tube surgery. Now coming where it works well, whether we thought that maybe because the silicone filled eyes, they don't do very well. So, but if the silicone is not there in the eye, if it has been removed, if the silicone is still in the eye, then it would be difficult because silicone pass through the tube and then it can, kind of get into the capsule, and that will result in failure. But if the silicone has been removed from the eye, then in this data which I presented, we actually looked at whether the silicon, presence of silicon or past use of silicon makes any difference in the success rate, but actually it didn't make much difference in this study. So I think more or less they behave in a similar manner. So if it is possible to put a tube at the right place, and if there's enough space and the tissue to fix the plate, success rate is not too different in in different secondary glaucomas, which I showed you, whether it's a post PK or it's a post retinal detachment surgery or post vitrectomy, and similar for the post uveitis as well.
Thank you, sir.
Thank you, both the presenter and panelists. I think we must go to the next presenter, and after that we will have some time for discussion. So can I request Dr. Gabo again to talk on the tips to improve your result with the another GDD, Ahmed glaucoma bulb. Dr. Gabo Lascaro, please.
I'm not allowed to share. Okay, now I'm allowed. Thank you. Yeah, first of all, congratulate Dr. Panda because of the excellent presentation. It's always good to learn from colleagues. We share many tips on the technique. So tips to improve your results with an AMED or a glaucoma drainage device. So to improve and to have good results in a long term, it is always better to start at the time of surgery. So this is what we always tell the glaucoma fellows. And I'm gonna share some small video clips to show you how we do, how we implant the bulbs in Mexico. We always try to use a traction suture because, like you can see in this video, we're using a 7/0 bicryl suture, and with an hemostat, we just fixate the eye looking forward, and then you get a great exposure of the temporal superior area, so you can have a very smooth surgery from the beginning. How do we start the peritomy? So we inject subtenons. You have to make sure that you are under or below tenons and inject the anesthesia. We usually use lidocaine. So you can see how a bleb is formed in the temporal superior quadrant, and with a cotton swab, you just touch the conjunctiva to increase the dissection. And look how easy becomes the peritomy. Of course, this is a regular case, not those difficult cases as the previous presentations. So peritomy becomes easy and faster. So injecting lidocaine subtenons. Then this is, fixation of the AMED or of the implant at the sclera is just in a regular form. What we usually do here is a long scleral tunnel technique. For that, we used a 23 or 22 gauge needle. So first of all, we go 6 millimeters posterior to the tip and bend the needle toward us. So this part of the needle is going to create the long scleral tunnel. And afterwards, we bend downwards the posterior part of the needle so we can get a C-shaped needle. So in this case, this form allows you to go all the way through the scleral tunnel. So I'm gonna go back a little bit, just why we want to do a 4 millimeters long scleral tunnel, because remember that the 4 millimeters behind the limbus is the area where the superior tarsus rubs the more. So we don't want to have this at the postoperative. So if you use a long scleral tunnel, it's better to make it at least 4 millimeters long. So this is an example, is something similar that Dr. Panda showed. We have in this case an erosion, a tube that is exposed. So what are we going to do here? We just do the peritomy, and using a needle, we cut the bleb, the roof, we unroof the AMED glaucoma bulb. Sometimes, I don't know how things are in Bangladesh, but in Mexico, people sometimes can't afford to pay like an scleral patch or a pericardium patch. So what we're doing here is cutting the bleb. In that case, we help to decrease IOP to this patient. So, and the tissue that we get from here, I'm gonna skip because of time. After relocation of the tube, we use that tissue as a patch, as a bleb patch. This is a very cheap technique. You don't have to pay for any patch, scleral pericardium, and this is the end of the surgery. So we get good results with this. We lower IOP, and we also cover the tube, allowing us to continue using the same implant. For me, the most important point when doing a long scleral tunnel is the traction suture, because you can see in this video how, I'm gonna pause it a little bit. So how when you go into the sclera, the needle is pushing downwards the eye. So, and what I'm doing here with the traction suture, I pull the eye so the eye can remain in the primary position. Look, when the tip of the needle is at the limbus, with this at this primary position, using the traction suture, you can redirect the needle so you can get a plane at the same plane of the iris. So look how I'm pulling the eye and the needle is pushing. So at that time I redirect the needle so I can get a good plane and avoid this. You know, this is we can get these tubes very often pointing towards the endothelium, or with a very long tube inside the anterior chamber. So what we recommend when we have this, I'm going to show you a video. I'm going to post it here. So what we're going to do is show you how to cut with an ab interno approach the tube. We create an incision over the tube in the green line, and then create a small incision 180 degrees apart from the first incision. So, oh, sorry, I'm gonna play it. So as you can see in this video, we have a long tube, we have epithelium edema of the cornea, so we create an incision over the tube. We use a 27 gauge cannula, so we cannulate the tube and go out the tip from the other side, at the other side, using the first incision. This is very useful, especially when you have finished the surgery and you consider that the tube is long. So you can, and you have sutured the conjunctiva, you can create 2 corneal incisions and cut the top. Also in patients where that have a previous AMED or a previous tube, and you're going to do cataract surgery, and the tube is long, before doing cataract, you can cut the top, use the tube using this technique, and use the first corneal incision to do the phaco as well. So this is a very nice and easy technique. What we do now is we inject mitomycin all the time in all the patients that have an AMED valve. We use 0.4 milligram per milliliter injection. We use 0.1 milliliter. We only not inject patients that have immunosuppression, but we do it in most of the cases. We inject at the time of the surgery, then do another injection at week and at the first month. So, and we started doing this with this trial that is going to be published soon in the Journal of Glaucoma. This is the AMED with mitomycin C trial. We collaborated here with UCSF University and all those centers. You can see in these 2 images, the one in the left is what we got in a lot of patients, an avascular bleb, an IOP on target. And we only had 2 patients with an image like in the right picture with no vessels or not vascularity at all. And this is not common using mitomycin. As you can see in this image, we got a decrease, especially for the group in which we use mitomycin. I repeat, at the time of surgery, week 1 and month 1, especially at month 1, that's the time when the hypertensive phase starts. So you have a better chance to improve the hypertensive phase using mitomycin. Also, we used a lower number of drops for patients in the group of mitomycin, especially after month 2. Success rate for these patients was 85 in the mitomycin group versus 67% in the BSS group. So these are my tips for a better chance to succeed in a glaucoma implant. This is my beautiful family, and I wanna thank you guys for the invitation. I'm very happy that you invited me to collaborate, and hopefully you can visit us soon in this part of the world. Thank you very much.
Thank you, Dr. Gabo Lascano, and thank you very much for showing your family. Very nice, very nice.
Thank you.
So we have learned many things from your presentation, and especially the MMC. Till now, there is no study showed that MMC in the tube has some more benefit. Probably you are going to show that. That is very nice. So before that, I am asking and I'm requesting Dr. Professor Iftekhar Mohammad Munir to have a comment on his presentation.
Thank you for giving me the opportunity. First of all, I want to give thanks Dr. Gabo Lascano for nice and informative presentation regarding Ahmad glaucoma valve. Actually, in our country, we use this Ahmad glaucoma valve in two situations, refractory glaucoma, and our surgical techniques also varies depend upon the patient presentations. So Dr. Gabo nicely present his presentation in different situation, how he customized the patients and the techniques of surgery regarding Ahmad glaucoma valve implantation very nicely. So I think our viewers today who are connected to us in this session, they are very much benefited for different tips and tricks regarding Ahmad glaucoma valve implantation. I want to give thanks Dr. Gabo once again for a nice presentation. Thank you very much.
Thank you, Professor Iftekhar Munir, and also Dr. Gabo. We'll have more questions at the end of the session, at the end of the speakers. So now can I go to the next speaker, to my friend, Dr. Sheikh Mohammad Hussain, and he is a member of Bangladesh Glaucoma Society. At present, he is the consultant glaucoma at the Deen Mohammed Eye Hospital and Research Center in Dhaka. And definitely he was our former professor and head of the glaucoma unit in the National Institute of Ophthalmology in Dhaka. Professor Hussain is going to talk on can multifocal intraocular implants be safely implanted in well-controlled glaucoma cases. The floor is over to you, Professor Hussain.
A very good morning, good afternoon, good evening to all of the viewers around the world. Trust everyone is doing well in this pandemic. Today, I'm going to talk on a very interesting but challenging topic, which is gaining momentum throughout the world slowly. Yeah, so the topic is multifocal intraocular implants, which can be safely implanted in well-controlled glaucoma cases. And the whole purpose is to determine whether multifocal implants can be offered to a select group of well-controlled glaucoma patients, intraocular pressure controlled after selective laser trabeculoplasty or after a single anti-glaucoma medication. So the methodology, I've chosen 9 eyes with well-controlled intraocular pressure after SLT or after single use of medication, which underwent cataract surgery with multifocal intraocular lens after detailed discussion of risks and benefits. 19 eyes with well-controlled intraocular pressure after SLT or a single medication underwent cataract surgery with multifocal intraocular lens implantation after detailed discussion of risks and benefits. Ocular comorbidity like age-related macular degeneration, epiretinal membrane, diabetic retinopathy, retinal hole were excluded. All surgeries were done by a single surgeon at Deen Mohammed Eye Hospital and Research Center, Dhaka. All eyes had well-controlled target intraocular pressure preoperatively. All patients on glaucoma medications continued them post-operatively in addition to standard post-op medications. Patients taking prostaglandin analogs preoperatively were switched to other medications preoperatively or underwent SLT to reduce intraocular pressure to target IOP. All achieved a minimum of 5 to 7 days of bromfenac 0.09% prior to and continued for 4 to 6 weeks after the surgery. So here's a little video clip regarding my surgery of the multifocal. And this is the beginning. I'm doing side port. Just a small video clip of like 3 minutes movie, just bear with me. And this is all surgery we do it. This is the factual surgery going on. And I'm going into the main session. This is a 2.2. And the nature of this cataract was nucleosclerosis plus 2. And the patient has got glaucoma of moderate here. Now I'm doing the capsulorhexis. Midway of it, it's almost done. So we are all familiar with this. And now the over the side doing the traditional drenching. And as you can see, it's like moderately hard cataract. The operation is done. We are trying to find the nuclear matter, and we almost at the end of cleaning up of the cataract part of the patient. Very well cooperative, and now I'm preparing for the multifocal. This is actually Symphony multifocal lens, and the power of this lens is 24 diopter. Now it is going into the eye. It's a very smooth lens, as we all know. Symphony has a very good character. The placement is also very smooth. And we are almost done. It is almost well centered, and that's all about it. So let me describe regarding this case. The patient was a female patient of 63 years old. Whose glaucoma was well controlled after serial SLTs and underwent this thickness multifocal. The patient's visual acuity on the right eye was 6.6 and left eye 6/12. Intraocular pressure 50 millimeter mercury both eyes. The OCT RNFL pre and serial post-op shows no significant change. Both the visual fields and optic disc changes were stable pre-op and post-op 9 months follow-up. And this is the pre-op OCT RNFL of the patient. And you can see the left eye, there's already a change in the RNFL. And This is also a serial analysis. This is a post-op. Nothing actually much change between the pre-op and the post-op. This is the third analysis, RNFL, and almost the same. Nothing has changed in this 9-month post-op follow-up period. And corresponding color fundus photography, pre-op and post-op, the disc is moderately pale and remains the same pre-op and post-op in 9 months period of time. And this is the visual field serial analysis pre-op and the post-op. The superior arcade scotoma is there pre-op and the serial analysis done. And here also nothing significant change in the two analysis pre-op and post-op. So case 2, male patient, 65 years old, whose glaucoma was well controlled by serial SLTs and underwent Tecnis multifocal both eyes. Uncorrected visual acuity OD 6.9 and OS 6/12. Intraocular pressure was 14 millimeter mercury both eyes. OCT RNFL pre and serial post-op shows no significant change. Both the visual fields and optic changes were stable pre-op and post-op 9-month follow-up period. So this is the pre-op of the patient OCT RNFL. This is actually moderate and between the moderate severe nerve damage is there. And this is a post-op, and it's almost the same in the follow-up post-op of a 9-month period. This is the Humphrey visual field analysis. This is serial analysis pre-op and post-op data going back into 3 analyses actually of this patient. And as we can see on the screen, the defect is almost the same. Now the results, all eyes achieved uncorrected 6 or 9 or better, and near vision and by 8 or better uncorrected vision, with intraocular pressure remaining controlled with the same medications as pre-op. 4 eyes actually received additional SLT. 3 eyes needed additional medications for a short period of temporary control of intraocular pressure. 4 eyes with previous filtering surgery, the IOP remained controlled with functioning blips. 8 eyes had reduction of intraocular pressure from pre-op level and were taken off medication. No eyes virtually had any intraoperative complications. All eyes had improved in uncorrected vision, and no eye sustained additional visual field loss. Perspective. Perspective in glaucoma changes to vision include, as we all know, is a loss of visual field and contrast sensitivity. And we also know that multifocal decreases the contrast sensitivity, which is an issue for many glaucoma patients. Having said that, some near premium intraocular lens have the ability to reduce distortion and improve contrast sensitivity. Tecnis Symphony intraocular lens is an extended depth of focus lens, EDOF, which does not reduce contrast sensitivity as compared with other monofocal lenses, decreases nighttime dysphotopsia, and boosts improved continuous vision adaptation. This is an important part of the Symphony intraocular lens, and any of my patients did not actually complain of this. So in summary, what should be the take-home message? Firm recommendations cannot be made on the use of multifocal in patients with glaucoma, as large studies have not been done to evaluate their benefits. Now, currently the decision to whether use multifocals in patients with glaucoma has to be made on individual basis. As technology improves and patients' expectations rise, we doctors treating glaucoma should consider offering premium options. But this is a subject of significant debate. So in conclusion, my thoughts actually, this is absolutely my thoughts. Multifocal implants can be offered to a select group of glaucoma patients whose intraocular pressure is well controlled with selective laser trabeculoplasty or single glaucoma medication. And in reference, all big shots, all big ophthalmologists, they are doing this multifocal in control glaucoma patients. I must give my immense gratitude and thanks to my mentor, actually, Professor Dean Mohammad Nurul Haq, for his academic input. I also give special thanks to Rakibul Hussain, Tanveer Ahmed, Shamsul Islam for preparing this presentation. Thank you all. Have a good day.
Thank you. Thank you, Professor Sheikh Mohammad Hussain, for your brilliant presentation. And we agree, the glaucoma patient must have the premium IOL. Why not? So without delay, I am requesting Professor Mizanur Rahman to have a comment on this presentation.
Thank you, Professor M. Nazrul Islam, for giving me the opportunity to comment on Sheikh Mohammad Hussain's presentation. Actually, it was a nice presentation, and nicely he has shown how the quality of vision is improved in a well-controlled glaucoma patient by using the premium IOL like Symphony. So it's a very good option for glaucoma patient, because due to damage of the optic nerve, there may be reduction of some postoperative visual quality. And that's why we may use the premium IOL for improvement of this quality of vision. I have a question to Dr. Sheikh Mohammad Hussain. Why you are using only Symphony? What is your experience regarding the other multifocal IOL, as for example, Restore or the Panoptix multifocal IOL? Have you any experience regarding that multifocal IOL? Dr. Sheikh Mohammad Hussain, please inform the audience what is your experience. Dr. Sheikh Mohammad Hussain.
Dr. Mohammad Hussain is online.
Please put him in the panel, please.
Dr. Mohammad Hussain, Sheikh Mohammad Hussain. He was in the panel. We saw him.
Dr. Surinder Pandab.
Yes.
Please, sir, have you any experience regarding the multifocal IOL implant in a case of a glaucoma patient? What is your experience?
I've been using multifocals for cataract patients, but when it comes to glaucoma, what glaucoma actually does to vision is that it reduces the contrast sensitivity. Of course, it reduces the visual field, but the contrast sensitivity is one thing which actually is less in glaucoma patient, and also the dark adaptation is also low. Now, multifocal IOLs, they also, generally speaking, they reduce the contrast sensitivity. When people say that one IOL is better than the other in contrast sensitivity, they are just relative numbers. But the fact is that all multifocals, by virtue of the design, there will be some reduction in the contrast sensitivity. So in this regard, when you're using a multifocal IOL for a glaucoma patient, so you have to be kind of a little careful and keep that in mind, that there may be a loss of contrast sensitivity in these patients. Other issues sometimes comes up with these is that they can induce changes in the visual fields as well. The visual field might actually deteriorate, not necessarily because of glaucoma, but just because the optics of the eye has changed. The contrast has gone down, and there may be some, they have some, abnormal, I would say, uh, the refraction in the eye is not the same as it was with a monofocal or a natural lens. So that sometimes can also change. And also when you're doing imaging, especially in OCT, multifocal lenses that can induce some artifacts in the OCT as well. So I think we have to be aware of, all these things that what a multifocal IOL can do from glaucoma diagnosis and, kind of a monitoring point of view, as well as some reduction in the contrast sensitivity. So I would say, because glaucoma is kind of a bit unpredictable, you can't really say when it's going to progress. So if you suspect the glaucoma is not well controlled, if it is already moderate to advanced disease, I would say I won't like to put a multifocal in that situation. But if you have an ocular hypertension,
Thank you.
with less risk factors, perhaps. Yes.
We don't have much time. We have only a few minutes till second
sorry
time.
for the glitch, because it was pre-recorded.
Okay, Dr. Hussain, only 10 seconds if you want to say anything. 10 seconds.
You know what? I mean, why I have chosen this? Because you know what, people coming, as these days, they all want to have, without glasses, even the, why not the glaucoma patients, they want to have the multifocal. So, I have chosen this a very debatable thing. It was only in 19 cases, but as I have said, lengthy studies has not been done over here and in the world also, but in some parts of the world they have already done. But some encouraging news are there. But why I have chosen the Symphony? Symphony has very peculiar and stable ability to reduce the contrast.
Thank you.
Of the other premium
Thank
lenses.
you.
Sorry.
It is 10:30, so we'll have to finish. Thank you, Sheikh Mohammed Hussain. And I'd like to thank all the speakers, Dr. Gabo, Dr. S.S. Pandab, Dr. Rabid, and Dr. Sheikh Mohammed Hussain, all the panelists, Professor Manna, Professor Mizan, Professor Munir, Dr. Salma, and thank you all the delegates who are in this session. Because it's 10:30, we don't have much time now. So sorry, we could not discuss many questions were there. We must be grateful to all of you and also to BGS to giving me the opportunity to discuss here to be the moderator. Thank you all, and at the end of the session.
Thank you.
Thank
you very much. Let's go to the next session, please.
Thank you.
Thank you.
Thank you.
Good morning, Dr. Nazrul Islam. Mayuri from America.
Yeah, good morning, Dr. Kamar. How are you?
How are you?
Fine. Thank you.
Good morning, ma'am.
Hi.
I'm Dr. Ruhi Mannan. I will be moderating the session.
Good morning.
Good morning, Purvi madam.
Good morning.
Dr. Vijaya, good morning.
Good morning. How are you all?
I'm leaving. Keep you here.
Okay.
Dr. Vijaya.
Next session. Okay. I'm leaving.
Hi,
Yeah.
Panda, good morning.
Good morning, everybody.
Dr. Panda,
Yes.
I'm keeping Dr. Panda with you. Dr. Panda will be with you in this session.
Yeah, I'm staying here.
Okay. Thank you very much. I'm leaving. Thank you.
Dr. Purvi, how are you? Seeing you after a long time.
Do you have?
Rohi, unmute, please. Dr. Rohi, unmute, please.
Good morning. Welcome you all to this scientific session 2 of 11th Annual National Conference of Bangladesh Glaucoma Society. I am Dr. Ruhi Mannan. I will be moderating the session. In scientific session 2, we will be discussing on review of glaucoma basics. Today, I am Dr. Ruhi Mannan, Scientific Secretary of Bangladesh Glaucoma Society, is the moderator of the session. We have as panelists with us, Dr. Hassan Shahid, Dr. Shafiul Islam Pradhan, Dr. Sheikh Mohammed Hussain, Dr. Kamal Hassan Khan, Dr. S.S. Pandav, and Dr. Purvi Bhagat as our honorable panelists. I will give a short introduction to all of my panelists. First, Dr. Hassan Shahid is the President-elect of Bangladesh Glaucoma Society, and he is ex-head of the Department of Bangladesh Medical College, Dhaka. Dr. Shafiul Islam Pradhan is ex-associate professor of Glaucoma Department of National Institute of Ophthalmology and Hospital and current EC member of BGS. Dr. Sheikh Mohammed Hussain is current EC member of Bangladesh Glaucoma Society and professor, ex-head of the Department of Glaucoma Department, National Institute of Ophthalmology. Dr. Kamal Hassan Khan is professor and head of Ophthalmology Department, Combined Military Hospital and Armed Forces Medical College. Dr. S.S. Pandav, he is current president of Glaucoma Society of India and professor of ophthalmology at Postgraduate Institute of Medical Education at Chandigarh. Dr. Purvi Bhagat, she is associate professor and head of glaucoma services, M&J Institute, Regional Institute of Ophthalmology. Today, as speakers, we have got 6 speakers, namely Dr. M.A. Karim. Dr. M.A. Karim is the life member of BGS and current director of glaucoma services at Chevron Eye Hospital, Chittagong. Dr. Zakia Wadud, he is the ex-head of the Department of Glaucoma Department, Lions Eye Hospital and Institute. Dr. Siddiqur Rahman, he is current director and chairman of Vision Eye Hospital, Dhaka. Dr. L. Vijaya, senior consultant, glaucoma services of Shankara Nethralaya and past president of Glaucoma Society of India. Dr. Iftekhar M.D. Munir, he is the current treasurer of Bangladesh Glaucoma Society and professor and head of the Department of Glaucoma Clinic at National Institute of Ophthalmology and Hospital, Dhaka. Dr. Mayuri Khamar, she is the ex-associate professor of glaucoma and current treasurer of Glaucoma Society of India. All of my speakers are allotted 10 minutes of presentation, except Dr. L. Vijaya and Dr. Mayuri Khamar. They will be given with 12 minutes of presentation. Analysts to comment for 1.5 minutes. So this was in short about the introduction of our session. At first, I would like to call upon Dr. Siddiqur Rahman to present his presentation on anterior segment OCT and OCT angiography. Dr. Siddiqur Rahman, anterior segment OCT and OCT angiography.
Thank you, Dr. Ruhi Mannan, and welcome all the panelists and the speakers of the session. I am now going to present my presentation and sharing my video. Dr. Ruhi, please. Okay. Moderator, panelists, and my dear ophthalmologist, Assalamu alaikum. Good morning. Welcome to my presentation, anterior segment OCT and angio-OCT in glaucoma. OCT is a very high technology and modern technology that we use to evaluate glaucoma in very early stages. Glaucoma is such a disease that has findings or signs in the anterior segment as well as in the posterior segment. And these images are very much familiar to us. We measure RNFL thickness and ganglion cellular thickness by the posterior segment OCT to evaluate glaucoma. Now, we can use the OCT to evaluate the anterior segment also. For anterior segment evaluation, usually we do use our slit lamp, gonioscope, gonio lenses, and applanation tonometer. With gonio lenses, we can get many informations, but an OCT can add some unique information that we cannot achieve from gonio lenses. We can measure the anterior-chamber angle accurately by the anterior segment OCT. And we can keep this record and can use for future reference and to counsel the patient for his treatment. In different light condition, people dilates or constricts, and sometimes these dilated people cause the development of angle closure crisis. So we can measure this by this OCT, and here we see the undilated pupil, the angle is open, and in the dilated pupil, the angle become crowded and prone to develop the angle closure crisis. So we can counsel our patient to about his or her danger. For intraocular pressure measurement, corneal thickness is a great factor, and we can measure this thickness of cornea by the OCT in the same sitting, same position. Now here is the patient's OCT of right eye. This is before the iridoplasty or iridotomy, and after iridotomy and argon laser iridoplasty, the angle become wider and open. And we can keep this record and can explain to patients what we want to do. We already achieved this. Anterior segment OCT has many other uses also, but in short, we can point out that we can use this to check the normal anatomy, angle wide, iris thickness, and anterior chamber depth, and screening angle closure disease also. To assess and document the plaque to iris syndrome, to test the efficacy of the laser peripheral iridotomy, and to measure the anterior chamber angle widening after laser peripheral iridoplasty. And we can assess or measure the position of the tube in implant. We can measure the blebs also. But all technologies has some limitations, and OCT, anterior segment OCT also has some limitations. We cannot see the pigments of the angle by this OCT. And after the iris or after the pigmented layer of the iris, we cannot see beyond this iris. So UVM is better for that. And after all, we can say the anterior segment OCT, gonioscope, and the UVM are not alternate to each other. And it cannot replace each other. Rather, all these equipments are complementary to each other, and we can get different information from all these equipments and tools and enrich our information from our patients. And dear ophthalmologists, now I am going to talk about the OCT angiogram in short. Actually, OCT angiogram is developed to diagnose and evaluate the retinal vascular diseases without using the dye. This is a very non-invasive way and non-toxic way to evaluate the retinal vascular diseases. In 2014, OCT studies by Dr. Huang and colleagues established that glaucoma reduces the perfusion at the multiple level of the optic nerve. Capillaries of the superficial disc and the laminate crevus are greatly attenuated. This is the retinal capillaries as we see through the OCT. This OCT classification, the superficial capillary plexus and the deep capillary plexus. Campbell et al. Found the capillary loss is most pronounced in the superficial vascular complexes than the deep vascular complexes. And now this is a question, how does OCT angiogram works? It doesn't use any dye. Rather, it uses the RBC's movement or motion of the RBC through the blood vessels, and it takes multiple scans of the same site, same position, and the difference between the pictures, the difference caused by the RBC's movement is detected by the software, and finally it creates the image of the angiogram. That means the vascular structure. And the software is developed by Huang and et al. Their group is split spectrum amplitude decoration angiography. And the OCT, especially the Fourier domain OCT, Swift source OCT, this hardwares, the very modern hardwares, made the clinical OCT angiogram feasible to us. You can see these images. This right side, this image is the in-face OCT, and here we see the ganglion cell layer is thin in this region, superior arcuate region, and the OCT angiogram of the same eye, we found this vascular density also less in this area, and this is very much correlated with the visual field defects, and we see here the visual field defects corresponds to the vascular deficit. Also, another example, this is a normal visual field and this is the angiogram we found, and the same patient's other eye, the visual field defect is very much significant, and the vasculature of the disc and disc and the parapapillary area is also less. We can compare this through these images, and we found the right eye is better vasculature and field is normal. Left eye the vasculature is less and field is tubular almost. Here is another example. Here is another interesting finding. The visual fields are almost same in both eye, but vision is 1/60 in the left eye and the right eye. This is 6/18. And we found in OCT angiogram this vasculature is better than this eye. So the vascular presence of the good vasculature at least preserve the vision even in the very latest stage. So the take-home message is the OCT angiogram provides a quantitative assessments of the microcirculation of the retina and the choroid in a fast and non-invasive way. And OCT angiogram seems to be able to detect the progression in glaucoma and might therefore be useful for the glaucoma follow-up. And OCT angiogram strongly correlates with the visual field, and therefore patients who are non-cooperative or unable to perform the visual field analysis can go for OCT angiogram. And OCT along with OCT-A or OCT angiogram benefits more in the glaucoma suspect patients or the pre-perimetric glaucoma patients. Along with IOP control, we think the future glaucoma management may be added value with the vascular issues. Future OCT angiogram should be a routine investigation along with the standard OCT and visual field analysis for our daily practice. And I acknowledge and very much thankful to all researchers and authors all over the world. Through internet, I get the information from their publications and a few pictures from their publications, and I mentioned their name here. And thank you all for patience hearing.
Thank you, Dr. Siddiqur Rahman, for your nice presentation. I would like to request Dr. S.S. Pandav sir to make his valuable comments as panelist on Dr. Siddiqur Rahman's presentation. So you have got 1.5 minutes for your comments. Pandav sir.
Yes, I think that's a very nice presentation and good overview of how OCT can be helpful in glaucoma, diagnosis, and also possibly in glaucoma progression. I think these are the new technologies, and their role is still getting defined in our glaucoma management. But OCT definitely, as far as nerve fiber layer thickness and imaging is concerned, it has a very well-established role now in detecting early disease as well as in its progression. However, the role of OCTA, for screening for angle closure is still evolving, and still to have more data on that, how effectively we can use it to detect angle closure. I think we saw some beautiful pictures where the OCTA could detect angle closure after dilating the pupil, but I think in the real community, whether how effectively can pick up glaucoma angle closure would still be, it's not really clearly answered. The question is definitely you have a technology which can help. Regarding OCTA again. This again, kind of emerging technology. We don't have experience with this as far as glaucoma progression is concerned. We definitely have a correlation between what we see on clinically, what we see on the optic disc and the nerve fiber layer, defects and defects on the OCTA. So there is a correlation between the two. But again, kind of whether you can pick up these diseases with OCTA before you pick up clinically or on perimetry, I think that issue still is kind of not very clear. But definitely we have something to look forward to, I think, and the refinements are is getting better every day. So I think we have some exciting things to come.
Thank you.
Thank you, sir. Our next speaker is Dr. M.A. Karim. He will be presenting on optic disc evaluation, how it helps to glaucoma diagnosis and prognosis. Karim. Dr. M.A. Karim, please. Dr. Karim, you have to unmute, please. Okay.
Okay. Thank you so much. My presentation is pre-recorded. I'm requesting to start the presentation.
Honorable panelist, moderator, and the audience, those who are attending the meeting, I welcome you all to my presentation on optic disc evaluation, how it helps to glaucoma diagnosis and prognosis. Optic disc assessment is an important tool in the early detection of glaucoma. Stereo photographs are widely used and available for evaluating changes. Visual field changes may be preceded by photographically documented structural changes of the optic disc. Glaucoma is a disease of optic neuropathy. If any patient have definitive optic neuropathy change along with nerve fiber layer defect or not, and if the patient has corresponding visual field defect, the diagnosis is easier and treatment is simple. Sometimes it's confusing, like this patient, 46 years male patient with normal intraocular pressure, have 0.6 cupping in the right eye and 0.7 cupping in the left eye. We suspect the patient as a normal rotation glaucoma and did the visual field, but the visual field comes normal in the right eye, and left eye showed another blind spot and also some depressed point in the superior field that may be because of the artifact. As the OCT comes normal, we send back the patient as a normal, but the patient comes after 5 years with definitive change of superior arcuate scotoma in the left eye, and OCT examination showed definite neuroretinal rim loss inferiorly. So the diagnosis was made non-moderation glaucoma. That could be possible before with careful examination. Now the careful examination showed the inferior neuroretinal rim is thin. Again, this patient have advanced retinal nerve fiber defect in OCT. It's a 30 years old female patient with normal intraocular pressure with 3 medication. So I did the visual field. The visual field comes normal. So the patient, we become confused after seeing the field as the OCT comes abnormal here. After examination of the disc, we found the patient have 0.8 cupping, both eyes with normal neuroretinal rim. The OCT change in this patient is because of myopia. The patient have 5 diopter myopia. Again, this patient is 39 years old, female patient, have 0.9 cupping in the right eye. Visual field examination showed normal visual field. In the left eye, 0.8 cupping. Again, the visual field also comes almost normal in the left eye. So what we did, we are confirmed about the diagnosis after seeing the disc. So we did the OCT, and OCT confirmed the diagnosis is perimetry glaucoma. So investigation sometimes confuses us. Even sophisticated investigation, OCT visual field may confuse, but in glaucoma examination, only thing is constant for all the patient is the optics changes. So optics examination is so very important. Evaluation of the optics is very important because optic head is the most important examination in the early diagnosis of glaucoma. Early detection, good prognosis; late detection, worse prognosis. Careful examination can detect the glaucoma at very early stage before visual field defect is apparent. Guidelines for assessment of the optic nerve head in glaucoma: size and shape of the optic disc and cup, new retinal, peripherally choroidal atrophy, retinal and optic disc hemorrhages, retinal nerve failure defect. Optic size variable. Small discs have a small cup, large discs have large cup, but the small discs have a small cup may be pathological, and sometimes the large disc, large cup may be normal. Cup size and cup disc ratio. There is an increase in cup size and cup disc ratio in glaucoma, though neither the cup size nor cup disc ratio by itself is helpful in distinguishing glaucoma discs from the normal disc. Asymmetry of cup size in both eyes also an important clue for the glaucoma. New retinal rim. In 83% of cases, it follows the Eisen rule. The earliest sign of glaucoma is the breakdown of Eisen rule. New retinal rim loss. If it is less than 2 o'clock area, we call it notching, and if it is more than 2 o'clock area, we call it thinning. Both are pathological and feature of glaucoma. Disc pallor. Cupping is the change in 3D contour of the disc, but pallor is the change in color of the disc. Pallor is an important indicator of glaucomatous damage and can sometimes be difficult to separate from the cupping. Like this patient, if you see the pallor and cupping is more than the pallor. Again, this patient also, cupping is more than the pallor. If the cupping is more than the pallor, we suspect glaucoma. If the pallor is more than the cupping, we suspect non-glaucomatous optic neuropathy. Peripapillary choroidal atrophy. Frequency and action of peripapillary choroidal atrophy is greater in glaucoma than normal eyes. It is alpha zone atrophy and beta atrophy. Beta zone atrophy is more common in the glaucoma. Disc hemorrhages. Splinter hemorrhage on the optic disc margin is an important sign of glaucomatous damage. Normally disappear after 1 to 3 months, indicative of glaucoma progression and worse prognosis. Detection of disc hemorrhage requires careful optic disc examination. Retinal nerve failure examination. Best performed using red-free light. Look for diffuse or localized retinal nerve failure loss. Y-shaped dark area in the picture showed the retinal nerve failure loss, so localized loss. And diffuse loss of straight pattern and increased visibility of retinal basal border indicate diffuse retinal nerve fiber loss. If you look at this patient, the patient is 64 years male patient with 16 intraocular pressure in both eyes, having 0.6 cupping in the right eye and 0.7 cupping in the left eye. We suspect the patient glaucoma, and we did visual field examination. Visual field examination in the right eye comes almost normal except some non-specific scotoma, and also in the left eye non-specific scotoma. We did swab. Swab comes completely normal in the right eye, and left eye showed some depressed point in the inferior field that does not correlate with the optic finding. Then we go for OCT examination. OCT examination, we did first Zeiss Cirrus OCT, and it comes almost normal in the both eye, except some thinner in the superior neuroretinal rim, and also one clock area thinning in the inferior rim in the left eye. Then we did Topcon Cirrus OCT to see the changes and to compare with the JAIS. In top cone OCT, the right eye comes completely normal, but the left eye showed one clock area, which one is suspected in the JAIS in a definitive thinning of the neurotendry rim. So we did more analysis with the OCT and found the right eye complete normal in all examination, and left eye showed inferior neurotendry rim loss, Y-shaped, and corresponding superior visual field loss in the left eye. All this investigation we did to confirm the diagnosis of the patient, and all costing investigation needs to confirm the diagnosis. On careful examination of the optic disc, it is apparent that the left eye inferior neurotendry rim is thinner and localized rim loss is seen here, and with careful examination showed some dark area that represents the retinal nerve layer defect. Same in the left eye retinal photograph showed some thinning area inferiorly with corresponding retinal nerve layer defect. The investigation we did to confirm the diagnosis of these cases could be possible with simple optic examination. So in conclusion, I like to say optic disc head examination is the single most important examination for glaucoma diagnosis and can possible to detect early and pre-perimetric glaucoma. Color fundus photographs, retinal photographs, and stereo photographs are important tool for the early diagnosis and monitoring the prognosis of glaucoma patient. Thank you all for patient hearing.
Thank you, Dr. Karim, for your nice presentation. I would like to request Dr. Hassan Shubit sir to give his valuable analyst comment on Dr. Karim's presentation. Dr. Hassan Shubit sir, please. Samir, please. You have got 1.5 minutes to make your comment, sir. Sir, you have time, sir.
Are you hearing me now? Hello?
Yes, you're audible, sir.
Are you audible now?
Yes. Yes, sir. Very much, sir.
Okay. Thank you very much. Thank you very much, Dr. Ruhi Mandan, the moderator, and the experienced ophthalmologist of the country or around the world. Good morning, good day, and good night to all. Well, nothing to add after the comprehensive presentation by Dr. M.A. Karim. Well, I'll try to discharge my duty as a panelist, stressing some points, pressing some point in this escalating ideas of about glaucoma. Well, stressing a point is the disc. Our topic is disc only. Large disc with smaller rims indicates reserve nerve fiber layer is less. So if there is a case like that and his family history is positive, that guy should be follow up. Large disc with smaller rims indicate lower reserve nerve fibers. Well, after testing with 90 diopter disc cup examination, if you have some suspicion, do pachymetry. See if the cornea is thin than normal. Do cribriform sclera is also thin. In those cases, do CSF pressure. CSF pressure as it is pushing from back and eye is pushing from front. There is something there. Follow and treat the case accordingly. And temporal crescent. While crescent around the disc, not only around, temporal crescent without myopia in hypermetropia.
Thank you, sir. So we have to move on to the next presentation.
Hello?
So we have to
Hello,
move on to the
hearing
next
me?
presenter, sir. So we have to move on to the next presenter, sir. Thank you for your comments, sir. I would like to request Dr. Zakia Wadud Madam to present her presentation on OCT in glaucoma practice. Madam Zakia Wadud. Madam, unmute,
Good morning.
please. It's a pre-recorded one.
Yes. Good morning, everyone. As it is recorded, please play the record.
Distinguished faculties from home and abroad, senior and junior colleagues, Assalamu alaikum. Welcome to my presentation on OCT in glaucoma practice. As we all know, OCT has become the gold standard for detecting early glaucomatous damage. However, to make the optimum use of this technology, we need to understand the potential limitations and pitfalls and be able to differentiate between a real defect and an artifact or anatomical variation. I will discuss some of the common artifacts that we come across. Before discussing the artifacts, we need to remember that in contrast to the early and moderate glaucoma, OCT becomes less useful in the follow-up of advanced stages of glaucoma because at this stage of the disease, progressive thinning of the retinal nerve fiber layer stops due to the presence of glial cells and retinal vasculature. So no more structural progression can be demonstrated. In advanced glaucoma, functional tests like the visual field supersedes OCT for monitoring glaucoma. Green and red are the main colors for the OCT platforms to indicate the results are within normal limits or abnormal. However, it should be kept in mind that these depend on the normative database of the manufacturer, which commonly includes 300 to 500 patients. The red disease is a false positive diagnosis where the software mistakenly identifies an eye abnormal, although there is no glaucomatous damage. Whereas the green disease is the opposite, that is, although there is some glaucomatous damage, the software is unable to identify it. Artifacts may be imaging artifacts or patient-related artifacts. Imaging artifacts may be due to poor image quality, which is associated with media opacities, dry eyes, inability to fix it properly, an unclean OCT lens, an older device, or an inexperienced operator. Or it may be due to segmentation errors associated with high myopia, tilted discs, or myelinated nerve fibers. Patient-related artifacts may be associated with split bundles or shifted RNFL peaks, media opacities like the Weiss rings, asteroid hyalosis, or vitreous hemorrhage. Vitreoretinal interface problems or optic nerve head drusen. When we evaluate an OCT scan, we look at the signal strength, which is the quality control metric of the OCT scan. The optimum signal strength recommended by different manufacturers is different. For the Zeiss Cirrus HD OCT, the signal strength should be 6 or more on a scale of 10. This is the OCT scan of a patient with bilateral uveitic glaucoma with posterior subcapsular cataract. OCT scan taken before cataract surgery shows poor signal strength and advanced RNFL defect. After surgery, the scan quality improves and there is less severe RNFL thinning. Low quality scans generally show thinner RNFL values with lots of artifacts. This is the OCT scan of a young female diagnosed as a case of glaucoma suspect with no other anterior or posterior segment pathology. The first scan shows poor signal strength and the wedge-shaped defect in the supratemporal part of the left eye with abnormal RNFL quadrant and clock hour graphs. On repeat scans, the signal strength was still low, so a device malfunction was suspected, and replacing the light source resulted in scans with better signal strength and normal findings. So this is an example of poor signal strength due to device malfunction. This is the OCT scan of a young glaucoma suspect with unremarkable anterior and posterior segment. The signal strength is optimum in both eyes. However, the RNFL deviation map shows significant movement artifact as indicated by the broken course of blood vessels in the right eye. Also, the RNFL quadrant and RNFL clock hour graphs are abnormal in the right eye. Rescan of the same patient with no movement artifact results in normal RNFL quadrant and clock hour graphs. So while reviewing an OCT scan, we need to check the on-fast OCT image in the RNFL deviation map and the RNFL thickness map in addition to the signal strength values. So here we can see the broken course of blood vessels, which indicates motion artifact. Before discussing this scan, we should remember that all OCT devices use segmentation algorithms or layer seeking algorithms to measure the thickness of the target retinal layers. If the software is unable to determine the layers correctly, segmentation errors will result and RFL thickness measurements will be flawed. So myelinated nerve fibers are common. The thick myelinated nerve fibers may hide the RNFL loss in glaucoma. It is one of the reasons for green disease. This is the OCT scan of a patient with ocular hypertension having myelinated nerve fibers. The RNFL quadrant and the clock hours appears white. So according to the color code of the Cirrus HD OCT, the thickest 5% fall in the white area. Being ocular hypertensive, this patient is a potential candidate for future damage. So monitoring the RNFL with OCT is not a good option for diagnosis and follow-up in such eyes. So for patients with myopia, tilted discs, or myelinated nerve fibers, where there is RNFL segmentation problems in the peripapillary area, macular ganglion cell analysis offers a better alternative. In most individuals, the superior and the inferior poles of the optic nerve head receive the largest number of retinal ganglion cell axons as two thick bundles. In some individuals, the superior or the inferior or both the bundles may be split and may enter the optic nerve head as two separate bundles. Split RNFL is a common anatomical variant and a common reason for red disease in the young. The OCT scan shows a localized RNFL defect in the left eye in the RNFL clock hour graph. If we look at the RNFL thickness map, there is split superior RNFL bundles in both the eyes. On the TSNIT plot, there are two prominent RNFL humps with a marked depression in between in both the eyes. So TSNIT profile evaluation is very important to differentiate the split RNFL configuration. Again, macular scans may be done and may be a better alternative in these individuals. If we carefully evaluate the TSNIT profile of this OCT scan, we can see that the graphs representing the RNFL thickness values have a double hump pattern, but it did not fit into the green area. The inferior RNFL peaks are shifted to the temporal side. In individuals with increased distance between the fovea and the optic disc center, or individuals with myopia or increased axial length, the RNFL bundles tend to shift to the temporal side, giving rise to the red disease. So here we can see the red line here depicts where the RNFL peak should have been and where it has been shifted temporarily. Floating vitreous opacities such as waist rings can cause patient-related imaging artifacts that manifest and disappear on different scans as their position changes with eye movements. In this scan, the position of the waist ring coincides with the calculation circle in the inferior quadrant of the right eye. So it results in scan failure and blockage and appears as zero RNFL thickness in the TSNIT graph in the inferior quadrant, which is technically impossible due to the floor effect. So when the scan was repeated after 1 year, the waist ring is still there, but it does not coincide with the calculation circle at the time of acquisition of the scan. So the pie charts also appear normal. This is the OCT scan of a patient with pseudoexfoliation glaucoma for 10 years and on 3 anti-glaucoma medications. But the ONH and RNFL scan appears normal. The inferior quadrant RNFL thickness in the right eye is high, which is probably caused by the vitreoretinal tractions corresponding to the calculation circle. So in the RNFL raw images, there are also, we can see vitreoretinal fractions. So macular scan, on the other hand, shows significant damage, which is compatible with the visual field findings, but not compatible with the RNFL and ONH scan findings. So for these patients, again, the macular scans may be a better alternative. So we need to keep all these factors in mind while evaluating an OCT scan. Keeping all this in mind will help us to come to a right decision regarding the OCT scan. Thank you everyone for your kind attention.
Thank you, Zakia Madam. Thank you, Zakia Madam.
Welcome.
Now, I would like to request Dr. Purvi Bhagat Madam to make her for your panelist comments. Purvi Madam, please.
Yeah. Thank you, Dr. Ruhi. And that was a very lucid presentation with very apt examples, Dr. Zakia. Congratulations. Basically, OCT for the RNFL has become a very important.
Madam, you're not audible. You're not audible. Okay.
Am I audible now?
Yeah, we can hear.
We can hear.
Yeah.
So
OCT for RNFL analysis has become a very important part of the glaucoma diagnostic armamentarium. And it definitely has lots of advantages that it helps us to quantify the RNFL in different sectors. It helps us to actually document and compare over a period of time. But the most important thing which I would like to highlight for the audience would be that even though it is a very important part, it cannot actually replace the clinical evaluation done by the disc examination. It is actually not a replacement, but an adjunct in a diagnostic armamentarium. So what you can directly see with your eyes through a disc evaluation, that cannot be replaced by an OCT. Because as Dr. Zakia elaborately discussed all those artifacts and the flaws and the problem of red disease and green disease, they cause a major issue in the diagnosis and management. So even though you may have an OCT, you subject your patient for an OCT analysis, just don't rely on it for your management of the glaucoma patient. You see a red disease and don't put your patient on a glaucoma treatment or advice for a surgery. So do a complete thorough evaluation. And again, it has a limitation in advanced disease, because once a majority of the RNFL is already gone, it is lost, then OCT RNFL analysis again has a very little scope, because then to pick up a progression or a further thinning in the RNFL becomes very, very difficult. So it is a definite adjunct, but just keep the holistic picture of all the investigations in mind and then use the OCT for management.
Thank you, Madam. Now I'd like to request Dr. L. Vijaya Madam to make her presentation on, are visual fields enough for assessing glaucoma progression? Vijaya Madam.
Give me just 1 minute. Can you see my screen?
No, Madam, not yet.
Okay.
Not yet, Madam.
1 minute.
The screen, Vijaya.
Yeah, just 1 minute. I will.
Yeah, sure.
You want to go to the next speaker so you can save time on it? I will just correct it. I think some.
Okay, sure. Sure, Madam.
Can I take up mine?
If you,
Vijaya, can I take up mine?
Yeah, please. because I don't want to waste
Okay,
it.
fine. We are moving on to our next speaker, Dr. Mayuri Kumar. She will be talking on gonioscopy for clinicians. Dr. Mayuri, madam.
Thank you. Can you see my presentation?
Yes, madam. It's visible, madam.
Okay, thank you. At the outset, I would like to thank Bangladesh Glaucoma Ophthalmic Society for giving me this opportunity to be within this wonderful conference. I will be putting up some of the polls that are useful for the clinicians in their practice. He may not be a glaucoma specialist. Now, why we do this gonioscopy? Because it is a fundamental part of the comprehensive examination. It should be done initially for all glaucoma patients or a suspect with the shallow chamber, and it needs repetition periodically. It is a dynamic process, and it helps in not only the grading of the anterior chamber angle, but also helps in the differential diagnosis of secondary glaucomas. Even in children, it helps us in a diagnosis as well as it provides the prognostic values and helps in assessing the changes in the angle morphology after doing LPI. And one should be expert in doing gonioscopy if he wants to do laser trabeculoplasty. Now, how we do the gonioscopy? There are basically two techniques, indirect gonioscopy and direct gonioscopy. Indirect gonioscopy can be dynamic. You can do the indentation gonioscopy or the manipulative. We will discuss that in the later part of my lecture. Now, the informational goals for the primary glaucoma is this angle open or closed in its natural position? What I mean is natural means very dim light of the room, not with the bright light. If the angle closure exists, is this the oppositional or a reversible angle closure or a cynical permanent closure? And if this angle is open, is this angle is likely to be occlude in the future? So first we interpret the angle structures. Which are the structures visible from anterior to posterior decides the narrowness and the openness of the angle. We look at the last iris roll at the configuration and pattern of the iris. This will help in diagnosing the occludability of the angle as well as give some syndromes and abnormal features like blood vessels, pigments or exudates presence. Now let us go back to our basics. This is a mirror. So whatever you see is exactly in the opposite quadrant. For example, the blood vessel which is situated here at 11 o'clock is seen in the inferior mirror when mirror is inferiorly placed at 7 o'clock. And when you rotate the mirror, the structures, they maintain the relationship. Now let us identify structures one by one. The anterior-most line, the glistening white band, and that defines the Schwalbe's line. Then is the pigmented and non-pigmented part of the trabecular meshwork. The anterior part is 1/3 is non-pigmented and posterior 1/3, 2/3 is pigmented. Third structure, the white band that you see posterior to the meshwork is scleral spur and then gray zone of the ciliary body band or angle recess. One can grade the angle depending upon various classifications available. But the most useful is the Spiess classification, which is based on 3 variants: angle width, site of iris insertion, and the peripheral iris curvature. The configuration of peripheral iris is steep or the regular or the queer, particularly seen with the pigmentary glaucoma. This is the regular and this is the steep curvature. Now, after that, you have to find out what is the angle width, which is the estimated angle or guesstimated angle between a line tangential to the trabecular meshwork and line tangential to the surface of the iris. Now, these are few examples of showing you how we create the angle. Here you see the balloon up iris is in contact with the cornea. No angle structure is visible. Here part of the meshwork is visible, which is grade 2. Here you can see the scleral spur, meshwork and the Schwalbe's line, that is grade 3. And this is the gray zone of the ciliary body band, that is grade 4 or the widest open angle. Now, when you have an angle like this, you can't see any angle structure. What you can do, either you do indentation gonioscopy with the 4-mirror gonial lens, or if you don't have that, you are using 1 or 2 mirror gonial lens, You can do manipulative gonioscopy. How we do it? Ask patient to look into the direction of mirror. For example, mirror is superiorly. Ask patient to look up and then tilt the lens slightly towards the center. This will give you over the hill examination, and you can see the oppositional angle closure which has opened up. This is a classic example of how this is the zero angle. You can't see the angle here. After manipulating, you can see the angle structure here. Now, indentation gonioscopy, how we do? With a small base flat curve gonio lens for mirror, you press it on the center of the cornea. That allows aqueous to push into the peripheral part, and that pushes the iris away from the angle if it is oppositional closure. And if angle remains closed, then it is a cynical angle closure. It is dynamic gonioscopy, indentation gonioscopy has a learning curve, but if you know it, you can identify many conditions like plateau iris configuration, phacomorphic animation, or induced angle closure, and many other things. Now, let us take few examples. This is a classic angle closure. You can't see anything. What you see is the corneal slit, which is being cornea being a transparent structure. You can see the anterior and posterior line, and these meets at the shawl base line. And from there, it becomes one single line and comes on the surface of iris. Here, these two are not meeting in one area. And on indentation gonioscopy, here where the corneal wedge is seen ending, this is the shawl base line. With the indentation, you can see the line is traveling into the angle, and this is a typical plateau iris double hump sign. Patches of the pigment is also a sign of previous angle closure. This is another case of plateau iris configuration. You can see the double hump sign. So this is another way of examining how we can differentiate the apex. This is the apex of the corneal wedge. This is the sempolysis line. You can see the angle here and the rays coming like this. So now this was the eye where the falsely it was diagnosed as an angle closure considering this pigmented area. But this is a typical plateau pigmentary glaucoma patients. You see the wedge is ending here. This is shawl base line. This is the part of the meshwork which is heavily pigmented, and there is a backward bowing of the iris. So this is how we do the recording, make a 4 quadrants, and first put down which is the posterior-most structure visible, then what is the amount of pigmentation, and what is the configuration of the iris. Now these are other abnormal things that you can see while performing the gonioscopy. Differentiate the amount of pigmentation. Like this is a classic example of the newborn baby. Nothing is, this is the whole angle, but no pigmentation. Here there is a patchy pigmentation, and this is a coarse pigmentation in a patches. Now this is the pigmentary glaucoma. You can see the Krukenberg spindle with a grade 2 to 3 pigmentation in the trabecular meshwork area. Now this is a post-op case who came after uneventful cataract surgery, but the uncontrolled glaucoma. You can see the jet black pigments all over the iris surface, and on doing the gonioscopy, we found out the pigments. This is not typical of pigmentary glaucoma, but this is a pigmentary inflammatory reaction, and this clogging is allowing this IOP not to go down even with the treatment. This patient needed surgery. Now iris processes are to be differentiated from the peripheral anterior synechiae. This is a lacy cord-like iris processes, and it should be differentiated with the PAS, which are broad, tent up like this, one single here, or multiple like this here also, but this is not the typical pass. This is a goniosynechiae. Now sometimes patient has a creeping angle closure, and you can have this kind of pattern closing of the angle. And sometimes the iris is plugging your window, and it is seen as this, or one single synechiae with the narrow angle warrants the laser iridectomy in that patient. Eye syndromes and many other congenital syndromes, they can have an anterior insertion of the iris with a stromal atrophy and broad peripheral anterior synechiae. The traumatic glaucoma may have an angle recession. It is shown here. Is a variable degree of cleavage between the circular and longitudinal fibers of the ciliary muscle, leading to exposure of the broad ciliary body band. This real angle is here, and this is the typical angle recession. Sometimes you can have a black ball sign. It's a sign of, here it is shown few black ball signs, which is a sign of previous eye edema. Always compare both eyes angle. That will also help you in differentiating the deep anterior chamber depth. Now, pseudo exfoliation beautifully seen on the anterior lens surface here. But when you see the gonioscopy, it has a more pigmentation compared to the normal, which is more of a patchy pattern, and the flecks or white fluffy material can be seen in the inferior angle. Here it is seen in the window of the trabeculectomy. Sometimes the whole pupillary rough is there, and this patient had a subluxation of the IOL with a fluffy matter into the angle. The normal vessel usually is solitary, never extends anterior to the scleral spur and never arborized, while abnormal vessels in the angle are shown here with the arborization and multiple branching. It's a case with recurrent unilateral glaucoma. You can see the obvious difference of the iris pattern here. And this patient had when we did the gonioscopy, we found out there was abnormal patchy pigmentation and the rest of the angle was okay. But while doing this photography, we started to see the pinkish area coming up, and eventually the whole angle was studded with the bleeding from the microvessels. That's a typical sign of Emsler sign. So it was a heterochromic iridocyclitis, which is unilateral and seen with the young male patient. Nevus or any tumor has to be documented and monitored regularly. This is a patient of ciliary body cyst or one single bump in this area. And we did the UVM and we found out there was an iris cyst. The silicone oil can be seen.
Madam, I guess we need to a bit sum up, please.
I will finish. So this
Sure,
is
madam.
congenital glaucoma with the abnormal iris processes and prominent Schwalbe's line. Always assess your angles after doing any procedure, whether it is successful or not. And never forget to see the disc in the end. Thank you very much.
Thank you very much, madam. Now I would like to request Dr. Shafiul Islam Pradhan sir to make his valuable comment as a panelist on Mayuri madam's presentation of gonioscopy. Dr. Shafiul Islam Pradhan sir, you've got 1.5 minutes to comment, sir.
Yes. Yes, thank you, madam. Dr. Mayuri Khamar, for your excellent, elaborative and informative presentation. Gonioscopy is the key method for the examining angle structures. It is the important tool for the glaucoma workup. Investigations like the UVM and anterior segment OCT, but for the angle evaluation, but these are the high-tech technology and costly and not available everywhere. But we can examine the angle by gonioscopy by simply slit lamp and all with a gonio lens. So we should do the gonioscope also the suspected glaucoma patient. But it is for the beginners, it is not easy to do the gonioscope. For this, we should do, which will make we to be an expert glaucoma specialist. Thank you, madam.
Sir, if you are finished with your comment, I would like to request Dr. L. Vijaya madam for her presentation.
Yes.
Madam's topic would be visual field, whether it is enough for assessing glaucoma progression. Madam Vijaya, please.
Yes, thank you, Ruhi. Sorry about the little mix-up I had. I hope now you are able to see my fields. Visual, my
very much visible.
Yes, thank you very much. At the outset, I would like to thank Bangladesh Glaucoma Society and Glaucoma Society of India for this kind invitation. And the next 10 minutes or so, I will be talking on visual fields are sufficient to detect progression. So whenever you see a visual field like this, that one thing that comes to our mind is what is the disk picture like? We always correlate what we see structure functionally with the structure. So what do we see in the correspondingly? We see a wedge defect here with the inferior notch, which is beautifully seen as a wedge defect in the red-free photography. So there is always a debate what is the relationship of the structure and function in the glaucomatous optic neuropathy. There are two questions that always comes to our mind. Is there a correlation between the location of the optic nerve defect and the nerve fiber layer defect and the visual field defect? The answer to this is yes, there is sufficient evidence to say that there is a correlation. And the other question that comes to our mind is more complex. Do structural and functional changes occur simultaneously? Which occurs first? And this debate went on and on for many years. But we do have sufficient information that tells us there is a curvilinear relationship between the two. That means the threshold values drop more slowly in the early disease and faster with the advanced disease. So when you look at it more critically, the Quigley et al. Have shown in the peripheral field, a 5 decibel sensitivity loss will correspond to 25% ganglion cell loss, and 10 decibel sensitivity loss will be 40% ganglion cell loss. In contrast to this, the central field, even a 5 decibel sensitivity loss will have almost 50% ganglion cell loss. That says the central fibers are more accurate and will have a more valuable information when you look at the white on white perimetry. So what does it mean? It means when you draw a relationship between structure and function changes, that's the disc and the visual field changes, in terms of the percentage of loss over a period of time. In the early part of glaucoma, the visual field changes will take time to happen, whereas the structural changes are seen very well. So the disc evaluation and the OCT evaluations will show more information here. Once the field changes happens, they deteriorate very rapidly. That means in moderate and severe glaucoma, where most of our patients in our subcontinent belong to moderate and severe glaucoma, the visual field's progression will be a good important tool to assess the progression. The visual fields are really valuable in moderate and severe glaucomas. So visual field progression, how does it look like? An existing defect may enlarge. It may get deeper with the points losing additional sensitivity. Normal areas of the field may get involved. Visual field fluctuation increases with the disease severity. New defects usually are associated with worsening of the previous defects. So any form of the change can be taken as a visual field progression. So historically, we have used different methods. We have looked at the clinical judgment. That means looking at all the visual fields. One important example is the overview printout on Humphrey Visual Field Analyzer. The other is the defect classification system, and this is mainly used for the multicentric long-term studies like AGIS scoring system. Clinically, we don't use it. Clinically, there are two important terms one should remember. One is trend analysis, other is event analysis. What is a trend analysis? It sequentially analyzes all the available visual fields over a period of time. The previous progression analysis on the Humphrey Visual Field Analyzer, that is a glaucoma change analysis, has used the trend analysis. What is the event analysis? It identifies a single event. It takes the initial two visual field as a reference, and whenever we repeat the field, it compares that day's visual field with the reference visual field and provides the analysis. Typical example is the previous GPA in the Humphrey Visual Field, that is the glaucoma progression analysis, is the event analysis. The one we use now is called the guided progression analysis, that is the GPA2, and it uses both trend and event analysis. It is an advanced version. It highlights subtle and early changes from baseline. is based on significant limits for test-retest variability in pattern deviation and helps to differentiate localized glaucoma damage from other source of vision degradation, such as changes in the pupil size, or maybe because of the cataract or ocular media effects. So if the previous one, the glaucoma progression analysis, as I said, it used to use only the event-based analysis, whereas the GPA2, that is the guided progression analysis, uses both event and trend analysis. So in both GPA and GPA2, there is no difference in definition of progression. And I was classified as a progressive damage if a negative linear regression slope was significant with a p-value of less than 0.05. So it is compatible with the CITA standard, CITA fast, and full threshold testing. Automated exam selection happens. We have to reconfirm that. Verifies reliability of the examination. It is familiar and simple reports. It also gives a progression indicators and also gives what we call it as a GPA alert. So in one look, it will give you facilitates a glance assessment, and it reduces the paper clutter, helps to assure that complete visual field history is considered, emphasize the importance of the rate of the progression. This is how a printout of a GPA will look like. I will go over it a little more in detail in the next few slides. So it gives both event and trend analysis, and it gives a GPA summary in a single page printout. It has three components, number 1, 2, and 3. The number 1 is the one on the top. It is called the baseline. Number 2 is the visual field history and trend analysis that includes the VFI plot and the VFI bar. And the third is the current exam that will be like an event analysis that compares with the baseline visual field, which is given in the top. So baseline automatically takes first 2 early reliable test, and it by default it is selection. If you are not happy with it, manually you have to correct it. Ensure that tests including the baseline are representative of the patient's actual baseline status. It potentially unreliable exams for the baseline exam are mainly because of the learning curves. That is, the first examination should not be used as a baseline due to marked learning effect. If it is false positives are more than 15% and more, try to avoid it. What is important is reset the baseline after surgical intervention, either after glaucoma surgery or with the cataract surgery. And again, relook at the progression. A word about the visual field index. The central points were weighed more heavily than those in the periphery, and reduces the cataract contribution to the measurement of the VFI. For example, if you see here A, the central points are not affected, and the visual, even though the field effect looks more or less the same, the VFI is 90%. Whereas in the B, where the central points are affected, where the scoring is given more value to the central point, VFI is only 81%. So central points are important in assessing the visual field index. VFI is a measure of the patient's overall visual function as compared to an age-adjusted normal population. As visual field loss progresses, the VFI value will fall. VFI of 100% represents a completely normal visual field. VFI of 0% represents perimetrically blind visual field. Relies on pattern deviation maps for identification of the abnormal test point, uses total deviation maps while calculating the depth of the defect at these points. VFI uses the central weighting to reflect cortical magnification from the increased density of the retinal ganglion cells at and around the fovea. Greater importance of the central fields for reading and seeing detail recognized. Has the ability to give a progression analysis even in severely depressed visual fields. VFI plot graphs the VFI values of all exams, including GPA analysis, a function of the patient's age. It provides linear regression. A minimum of 5 exams are needed. VFI bar gives you valuable information about the VFI score likely to be in the next 5 years. For example, if you look at here, this is the first visual field, which was having a VFI of 92%. Over a period of time, patient has progressed. It has come down to 67%, and it is easily seen. And the rate of the progression gives is in the regression line, and which is minus 2.9, which is more than the accepted 1 decibel loss per year. And it also provides what we call it as a VFI histogram. So what does the VFI histogram tells us? It tells us if the patient is maintained at the same stage, what will happen in the next 5 years, what kind of a progression will happen. So a possible progression in next 5 years is given here. So it is a beautiful way of depicting the visual field progression. Coming to the current examination, we should not depend upon only on the VFI. We also have to look at how much the patient current exam is deviating from the baseline. And you have to look at very carefully the points which are decreasing, and you have to look at what we call it as a progression analysis. Again, what does the progression analysis say? It has indicators. If you look at a closed circle, black circle like this, no significant change from the baseline. These are the points. If you see an open triangle, a deterioration from baseline 1 time. If you see a half-filled triangle, a deterioration from the baseline in 2 visual fields. If you see a totally filled up triangle, deterioration from the baseline in 3 visual fields, which is a significant thing. So this is a event analysis. So event analysis also is important. You have to pay attention to the individual points. So it also gives possible progression whenever significant degradation is seen in the same 3 or more points and 2 consecutive follow-up tests. You will get a positive progression warning there. And a likely progression, if it is in 3 consecutive follow-up visits, if you see the points, it says likely progression. And you can also get what we call it as a single field printout with the GPA information, where you will see the visual field index and the GPA information box also you will get. You can, with a quick look, you can look at it.
We need to sum up, please.
Yeah, I will. Next 1 minute. You will see there is a progression in multiple points with a close triangle. So these are, I will skip this thing. So in conclusion, the GPA is a clinically useful tool for evaluating visual field progression. GPA printout provides a comprehensive analysis of the visual field change. The GPA contains both a trend analysis and an event analysis. VFA is a new parameter, gives, you can use it with a quick look, what is the visual field like. All portions of the printout should be examined carefully with special reference to examination selection and quality. Thank you very much.
Thank you, madam. Thank you very much. I would like to request Sheikh Mohammed Hussain sir give his valuable comment as panelist on Vijaya madam's presentation. Hussain sir, you have got 1.5 minutes, please.
Thank you, Dr. Ruhi. The giant in the field of glaucoma has spoken. You know, I don't have any comments, but I can only emphasize and re-emphasize what Dr. Vijaya has said so explicitly. Everything. Like in clinical significant rate of progression of glaucoma that could lead to high risk in the future impairment of visual acuity is very important. The only the trend-based analysis can be used to evaluate these changes. There are some very newer technologies, and Madam has already said, you know, like Zeiss software, which has got both structural and functional testing and can help in the measure of the GPA. Another good technology is like GDX VCC guided progression analysis software, which is called GDX GPA. Now it has got 2, 3 also. Is also helpful in this regard and has got a huge emphasis in this progression analysis. Now the point to ponder and to emphasize what Madam has said. I can only re-emphasize the thing is that in early changes of glaucoma, when OCT reveals only the structural change, but the visual field remains the same. There's no change in the visual field in the very early stage. But having said that, we have to remember also that the state of the art of OCT frequently misses further loss of the areas that have already undergone extensive structural damage. And one very important thing here, we have to choose clinically while doing the progression with the field analysis is that which algorithm we have to follow. The most, significant one, which is worldwide we are using is that CETA standard 24-2 perimetry, and also CETA fast.
Sir, we have to move on. So we have to move on. Thank you, sir. Sir, on the next presentation.
Thank you.
I would like to request Dr. Iftikhar Mohammad Munir, sir, to present this topic. This topic today is UVM, how it helps in glaucoma diagnosis. Munir, sir, please.
Assalamu alaikum. Welcome everybody to my pre-recorded presentation. I would like to request concerned person to start it.
Honorable panelist, moderator, and respected viewers, Assalamu alaikum. Welcome everybody to my presentation. UVM, how it helps in diagnosis of glaucoma. Ultrasonography is a diagnostic tool in ophthalmology. It is a non-invasive method and provides qualitative and quantitative assessment of the globe. On frequency, UVM is 30 to 80 MHz. Normal B-scale which is used in ophthalmology is only 10 MHz. In biometry scan, it is 10 to 12 MHz. In abdominal and ultrasound, it is only 1 to 5 MHz. UVM provides high resolution image of the interior chamber structures anterior to first planar region and provides two-dimensional grayscale images. In the late 1980s, Pablin, Scherer, and Foster developed a wonderful instrument. On principle, it is similar to V-scan at the frequency, less at the tissue penetration, but better image resolution. UVM machine consists of 3 functional components: transducer, signal processor, video monitor. Transducer has the crystal. It converts electrical energy to ultrasound, and this ultrasound when reflected from the tissue, it produces two-dimensional images on the video monitor. Now the technique of the UVM, as it is conduct procedure, patient is in supine position, local anesthesia, eye cup is placed to the eyeball for small water bath. Methylcellulose or normal saline can be used for coupling solution. Transducer is placed 2 mm above the eye surface. The reflected signal is well detected when ultrasound beam strictly perpendicularly. The image is displayed on a video monitor and can be recorded. Now the difficulties of the UVM, as it is contact method, so it is difficult in children and non-cooperative patients. Undue pressure of the eye cap can distort the angle structures. The scanning beam should be strike the tissue perpendicularly, otherwise it will be distorted. UVM assessment. UVM can assess both quantitatively and qualitatively. Quantitative assessment includes simple measurement methods like distance measurement and angular measurement. Here we see angle can be measured by defined tools: angle opening distance, angle versus area, trabecular iris surface area. By this tool, we can easily assess the angle of the anterior chamber. By different caliper, we can also measure the iris thickness at different locations. We can measure central corneal thickness, anterior posterior chamber depth, IOL thickness, anterior body thickness, scleral thickness. Qualitative assessment. Like qualitative assessment, we can measure the glaucoma, different type of glaucoma, and also the different entry segment pathology. But today my topic is only glaucoma. UVM in glaucoma. UVM can assess anterior chamber angle, biometry of anterior segment structures, mechanism of different primary and secondary glaucoma to determine occludability of the angle, congenital glaucoma when there is opaque. Let us try to see different images by which we can assess the different type of glaucoma. Pupillary blood glaucoma before and after LPI. Here we see before LPI, iris configuration is a bit convex and the angle is less. But after LPI, iris surface is flat and angle is negative locally. Plateau iris configuration. Here we see ciliary body are rotated anteriorly, so pull the root of the iris more anteriorly, so angle will be less. It is the double hum sign in UVM, one hum by the periphery of the lens and another hum is provided by the root of the iris. So by this UV double hum in UVM, we can easily diagnose the plateau iris configuration. Occludability of the angle in lighted and dark adapted condition can be also assessed by UVM. Here we see in the dark adapted condition, iris configuration is a bit complex and root of the iris in contact with the trabecular measure. But in light adapted condition, people is small, so iris is relatively fat and root of the iris is away from trabecular measure. So we can assess the leaks of the neural glaucoma by UVM. In pigment dispersion syndrome, we say angle is widely open, posterior the root of the iris, posteriorly blowing showing here, and so there is friction of the pigmentary layer of the granule and liberation of the pigment which is distributed from the anterior segment. In the opaque media, UVM can also assess the extent of the peripheral anterior synechia. In malignant glaucoma, here we see the ciliary body is rotated anteriorly and the process is also narrow. So ciliary ring is narrow, aqueous humor is directed posteriorly. So anterior chamber goes central in peripheral elevation of here is the rotation of the ciliary body. So UVM in malignant glaucoma detect the basic pathology of the malignant glaucoma. Functional status of the filtering structure. Here we see the deep sclerostomy, interscleral, aqueous leg, functioning ability of the blood wall and subconjunctival fluid. So UVM can assess the functional ability of the blood vessels. UVM can also detect the glaucomatous device, its location, and is there any deviation of the blind tube position, is there any tube blockers. So then the glaucomatous device can also assessed by the UVM. Traumatic glaucoma, particularly in the opaque media, angle recession, iridodialysis, sectordialysis, tubular rupture, and hemorrhagic cyst within the lens can be also assessed by UVM. Here we see root of the iris is distal posteriorly and ciliary body is well visualized in angle recession. Ciliary body is separated from the scleral spar, so sectordialysis can easily diagnose. In congenital glaucoma, here we see ciliary body is elongated and abnormal material in the angle view. The root of the iris is inserted more anteriorly. So in opaque media, congenital glaucoma is properly evaluated. Here we see growth is extending from the ciliary into the anterior and posterior chamber region. Trabecular topiramide induced angle closure. Here we see the ciliary effusion and thereby topiramide history and by detecting this superciliary effusion and the pyramid into closer. Limitations. UVM cannot visualize structures deeper more than 5 millimeters from the ocular surface. UVM cannot be performed in open rooms or just after surgery. Risks of infection spread for corneal abrasion due to contact nature of the illumination. Image distortion if transducer is not perpendicular to the target tissue. No summary. UVM did revolution in evaluation of the anterior segment of the eyeball. UVM can use as education tool. UVM visualize all structure and spaces behind the iris plane. These other devices like optical evaluation, CT, and CAM cannot visualize the structure at the iris level or ciliary body region. And this is the beauty of the UVM.
Thank you. Thank you, Moni sir, for your presentation. I would like to request Kamrul Hassan Khan sir for your valuable opinion on Moni sir's presentation. Kamrul sir, you've got 1.5 minutes, sir.
Am I audible, Dr. Ruhi?
Yes, sir. Very much, sir.
Thank you very much, Dr. Moderator, Dr. Ruhi. Best wishes to all the speakers and panelists. It was just a wonderful presentation given by Dr. Munir. He has given elaborately regarding the UVM, the functional modalities of the instruments, how it works, what is the procedures we can do it, and how we can interpret. It is all self-explanatory. Definitely, for the last few presentations we have seen, as the days progresses, a lot of new devices are coming, and most of the devices are supplementary to each other. None can replace another one. Just for one particular issue, I want to emphasize with Dr. Munir that UVM is phenomenally helpful for the ciliary body tumors, particularly the configuration of the tumors, whether it is solid or cystic, how is the extension of the tumor, because all other devices, we can just detect some of the devices that there is some growth behind the iris, but this is the only device by which we can see whether it is a cystic lesion or it is solid lesion, how is the extension, and by this we can help to plan the treatment plan, how we'll go for this treatment of this growth. Otherwise, all the modalities you have shown, it is very, very good, and it is definitely in the future days it will be helpful for us. Thank you very much for allowing me to talk. Thank you.
Thank you, sir. I am thanking all of my panelists and speakers for being present with us and for deliberation of their nice presentations and comments. As we have got just our inauguration ceremony waiting, all the attendees are waiting there. We'll leave whoever so, and only the ASIC members will attend the session and whoever wants to. Thank you, sir and madam. Thank you very much.
Thank you.
Thank you, Dr. Ruhi. Very nice, nicely moderated. And I must thank Dr. Bijay Lingam, Madam, Purbe Bhagat, and Dr. S.S. Pandab. Long time he is with us, 3 hours. Thank you so much. Thank you so much.
Thank you.
And Dr. Mayuri Khamar. Thank you very much, and all our friends here.
Bye.
Thank you so much.
Thank you.
Thank you. We have to see you, and please try to watch our presentation in other sessions as a delegate.
Thank you. Thank you.
Thank you.
Thank you.
Okay.
Sharfuddin bhai, assalamualaikum.
Assalamualaikum.
Assalamualaikum, madam.
Waalaikumsalam.
Madam, assalamualaikum.
Join Kursen.
Assalamualaikum, sir. Sharfuddin, sir.
Waalaikumsalam. Jaul Karim. Assalamualaikum. Kamrul ji.
Sir to join করছেন বলে।
হ্যাঁ করছি।
স্যারও জয়েন করছেন।
স্যার আসসালামু আলাইকুম স্যার।
আসসালামু স্যার।
আসসালামু স্যার।
আমি তোমাদের অনেক সময় ধরে দেখতেছি।
শুধু আমাদের চেহারা স্যার এই এখন দেখা গেল, এতক্ষণ আমরা বাইরের থেকে ওদের দেখছি।
প্রেজেন্টেশন দেখাটাই তো আসল।
আমি
জি স্যার। স্যার আপনি আপনার ভিডিওটা অন করেন স্যার।
আমার ভিডিও অন করা নাই না।
না স্যার।
এখন ঠিক আছে।
হ্যাঁ হ্যাঁ ঠিক আছে স্যার।
আসসালামু আলাইকুম স্যার।
বুঝছি ওই
স্যার আসসালামু আলাইকুম।
হ্যাঁ ভিডিও ইচ্ছা করে অফ করে রাখছিলাম ওই প্রেজেন্টেশনের সময়, কারণ ওতে যে প্রেজেন্ট করে ওদের ডিস্টার্ব হয়।
স্যার আপনার শরীরটা ভালো স্যার? মাস্ক পরা কেন স্যার?
মাস্ক ওই বাসা ক্লিন করতেছে একজন, সেই জন্য।
ও আচ্ছা আচ্ছা আচ্ছা, ডাস্ট ফর প্রিভেনশন অফ ডাস্ট।
সর্বদিন স্যারকে দেখে আমরা তো দেখতে পাচ্ছি না
স্যার। আমি এখন পরীক্ষা নিয়ে আসলাম স্যার।
শুরু করেন।
আর জিয়া সাহেব
দেরি করলাম।
আসসালামু আলাইকুম। We are now
হাসান সরওয়ার্দী ভাই, আসসালামু আলাইকুম।
আসসালামু আলাইকুম সরওয়ার্দী স্যার।
ভাই
স্যারকে তো চেহারা দেখতে চাচ্ছি স্যার। মুদাসসির স্যার।
স্যার
সুবিধা তো যে একজনই মাস্ক পরে।
Thank you all for your participation. Assalamu alaikum. I like to start the inauguration ceremony. Assalamu alaikum. Welcome you all to the inauguration ceremony of 11th Annual National Conference of Bangladesh Glaucoma Society. I am Dr. Salma Parveen, Secretary General of Bangladesh Glaucoma Society. This ceremonial event will be presided by Professor Muhammad Mizanur Rahman. Professor Syed Mudassir Ali, ex-advisor to the Honorable Prime Minister, People's Republic of Bangladesh, is today's chief guest. Professor Abha Hussain, President, Asia Pacific Academy of Ophthalmology, and Professor Muhammad Sharfuddin Ahmed, President, Ophthalmological Society of Bangladesh, are the special guests to this occasion. Professor Abdul Kader, Secretary General of Ophthalmological Society of Bangladesh, is our today's guest of honor. May I request President Bangladesh Glaucoma Society to conduct and preside over the session. Professor Muhammad Mizanur Rahman.
ডক্টর সালমা, এটার ইকো হচ্ছে কেন দুইবার? নজরুল ভাই ওটাকে একটু Thank you, Dr. Salma. Honorable Chief Guest, Professor Syed Mudassir Ali sir. Honorable Special Guest, Professor Abha Hussain, Professor M.D. Sharfuddin Ahmed, and ইকো কেন হচ্ছে? ম্যাডাম এখন কি ঠিক আছে স্যার? এখন
না এখন ইকো হচ্ছে না, তোমার বোধহয় ইকো হচ্ছে।
Fine, there is no echo in the
Okay. No echo.
We are fine.
হৃদয় ইকো কেন হয় দেখো তো একটু।
স্যার আপনি প্লিজ কন্টিনিউ করেন, আমরা শুনতে পাচ্ছি ঠিক
There
তো।
is no echo from our side.
মিজান ভাই, আপনার ওখান থেকে কোনো প্রবলেম হচ্ছে, আপনি কন্টিনিউ করেন।
আমার মনে হয় প্রেসিডেন্ট সাহেব একটু অ্যাপোলোজাইজ করেন যে হঠাৎ দুটো একটা নাম এই ইকোর জন্য যদি না শোনা যায়, মাপ চেয়ে।
আচ্ছা সবাই একটু বন্ধ।
কাদের সাহেবের নাম শোনা যায় নাই, তো প্রেসিডেন্ট সাহেব ওটা বললেন সবাই তো বোঝে যে এটা ইকো হতে পারে বা এখানে একটু ট্রাবল হতে পারে, মাফ করে দেবে। হ্যাঁ কিন্তু এটা বলে নেন প্রেসিডেন্ট সাহেব, কারণ কি
আমি কন্টিনিউ করব?
হ্যাঁ
প্লিজ কন্টিনিউ করুন।
Please continue. Everything is all right. No problem.
Okay. একটু সবাই মিউট করে রাখলে। Okay, thank you. Thank Dr. Salma. Honorable Chief Guest, Professor Syed Mudassir Ali sir, Honorable Special Guest, Professor Abha Hussain, Professor M.D. Sharfuddin Ahmed, and Guest of Honor, Professor M.D. Abdul Kader, BGS EC members and advisors, foreign delegates, participants, ladies and gentlemen. I welcome you all in the inauguration ceremony of the 11th Virtual Conference of Bangladesh Glaucoma Society. Now, I am requesting Dr. Salma Parveen, Secretary General of Bangladesh Glaucoma Society, for address of welcome. Dr. Salma Parveen, please, address of welcome.
Thank you, President of Bangladesh Glaucoma Society. Respected President, Chief Guest, Special Guests, Guest of Honor, Executive Committee members, life members of Bangladesh Glaucoma Society, President and Secretary of Ophthalmological Society of Bangladesh, faculties from the Bangladesh Glaucoma Society, Asia Pacific Glaucoma Society and Glaucoma Society of India, and other foreign faculties, distinguished guests, member of different pharmaceuticals company, ladies and gentlemen, Assalamu alaikum and very good morning to all. In this month of victory, we are starting our session by showing due respect and gratitude to martyrs who sacrificed their lives for the freedom and sovereignty of our motherland, Bangladesh. Although you know we are passing a very harsh time due to COVID pandemic, even though we are trying our best to keep our academic activities alive. On behalf of Bangladesh Glaucoma Society, it is indeed a pleasure, honor, and privilege for me to welcome you all today, 18 September 2020, to this virtual 11th Annual National Conference of Bangladesh Glaucoma Society. Bangladesh Glaucoma Society started its journey on 3rd November 2007. Since then, we are arranging annual national conference each year and international glaucoma meeting biennially. Current executive committee has taken over their responsibility on 10th February of this year. This year, we observed World Glaucoma Week very elaborately, and we observed World Glaucoma Day on 14th of March this year. Throughout the week, we have arranged free glaucoma screening, colorful rally, talk show on glaucoma in television and radio, poster distribution for awareness among the people. Awareness of glaucoma is very low in spite of being the second leading cause of blindness. As much as 40% of vision can be lost without a person noticing. So it needs to be addressed properly. As the case detection rates are very low, we are lots of undiagnosed cases. Honorable participants, for treating the patients properly, knowing glaucoma more precisely, we need to educate ourselves. Conference is the place where you can share our knowledges, meet and greet people who are working with the same focused subjects. I want to give my heartfelt thanks and gratitude to Asia Pacific Glaucoma Society and Glaucoma Society of India specialists for accepting our invitation. Make their valuable time for our conference in spite of their very busy schedule. I'd like to give thanks to all the local speakers, panelists, and moderators for their best cooperation. The scientific subcommittee gave their highest efforts for making the conference a very successful one. I thank them to all, especially Professor M. Nazrul Islam and his team. I also thank Professor Sheikh M. Mannaf as our all-time guide. I welcome our today's chief guest, Professor Syed Mudassir Ali Sir, ex-advisor to the Honorable Prime Minister, Government of People's Republic of Bangladesh. Special guest, Professor Abha Hussain Madam, President-elect, Asia Pacific Academy of Ophthalmology, Professor Sharfuddin Ahmed Sir, President, Ophthalmological Society of Bangladesh, and guest of honor, Professor Abdul Qadir, Secretary General of Ophthalmological Society of Bangladesh, for their valuable presence to this inauguration program. I'd like to welcome all the advisors, EC members, BGS members, local speakers, and distinguished foreign speakers from APGS and GSI and other countries. I'd like to express my thanks and gratitude to the industrial partner for their continuous support. I hope our today's BGS conference will be an excellent one with all your support. From my side, I welcome all the participants. Thank you. Now, I request the President of Bangladesh Glaucoma Society to conduct the rest of the session. Thank you. Conference, excellent one. All your support. My side, I welcome all the participants. Thank you.
Thank you, Dr. Salma, for your nice presentation. Thank you, Dr. Salma Parveen. Now I am requesting our guest of honor, Professor MD Abdul Kader, Secretary General of OSB, to deliver his speech. Dr. MD Abdul Kader. Dr. Professor Abdul Kader, probably he failed to join. So we can continue. We can continue. I think he will join later on. Now I am requesting Professor MD Sharfuddin Ahmed, President of Ophthalmological Society of Bangladesh and Chairman of Department of Ophthalmology, Bangabandhu Sheikh Mujib Medical University. Please, you are requested to deliver your address. Professor MD Sharfuddin Ahmed.
Unmute, please unmute.
Yes, thank you. Thank you, Professor Mizanur Rahman, President, Bangladesh Glaucoma Society. And firstly, during this Congress, Bangladesh Glaucoma Society, I think Professor Syed Mudassir Ali, our chief guest, who is the grand teacher of this country, and he was the advisor to the Honorable Prime Minister. Even he is also advising our Prime Minister today also, our guardian, our father-like teacher, Professor Syed Mudassir Ali. Also, another guardian, Professor Abha Hussain, who is the President-elect Asia Pacific Academy of Ophthalmology. She is also with us as a special guest. And all other Bangladesh Glaucoma Society EC members, whole-time guide, and other past presidents of BGS, new elected president, also other EC members, and the other foreign faculties from Asia Pacific Glaucoma Society and also Glaucoma Society of India, and all other participants. I welcome you all, and it's my pleasure to welcome in this inaugural session as the special guest and also as the President of Ophthalmological Society of Bangladesh. I think this Congress is 11th Congress. And why it is virtual? It will be in the history after few years that why this conference is virtual because of Corona. And you see, even though during Corona, I think Bangladesh Glaucoma Society is working hard for performing some international webinars, also academic activities. Also, they are giving support to prevent glaucoma in the country by awareness program. I can remember that last year when there was the Glaucoma Week, I had the opportunity to inaugurate it in Harunai Foundation, and also I have seen there was a scientific program. There was in SPICE, there was another dinner and scientific program also. And nowadays we cannot meet together because of this Corona pandemic. We are here in the same screen. Even though we are far away, but we are very nearer in the screen. I thank the organizers that they have already started some scientific programs. I have also attended one of the program which was presented by Dr. Munir as the topic was UBM. And I think in future, what we are to do. All ophthalmologists should be concerned because of the silent killer glaucoma. It should be screened. Many patients are still undiagnosed. How we can make all the patients diagnosed by screening, that should be done through Ophthalmological Society, also with the help of Bangladesh Glaucoma Society. You can come forward and we will be able to screen it, and we can prevent blindness from glaucoma in our country. This is the victima. We have already, Salma already mentioned. I pay respect to our father of the nation, Bangabandhu Sheikh Mujibur Rahman, all the freedom fighters and all martyrs who sacrificed their life during this freedom fighters, during this liberation war. And also, I remember our ophthalmologist, Dr. Alim Chaudhry, who was one of the ophthalmologists, and many other ophthalmologists, they sacrificed during this time. About 10% of all the health professionals, they sacrificed during the freedom fighters, during this liberation war. I thank all of you who are attending here. Once we heard that the glaucoma patients are there, about 1.8. Sometimes another statistics was told 2.4%. But what is the actual? We should find it out by screening. In future, Bangladesh Glaucoma Society will come up for screening it and for the prevention of glaucoma in our country. I thank all the organizers who invited me as a speaker today. I will not take much more time because after some time we have to go for prayer. I will thank all the chief guests, special guests, all the faculties, foreign faculties, Asia Pacific Glaucoma Society and Glaucoma Society of India, and all the EC members of Bangladesh Glaucoma Society who has invited me and gave me the opportunity to talk in front of you. With these few words, I wish all the success, and not only the inauguration, the conference of Bangladesh Glaucoma Society should be a successful one. This is my wish. Thank you very much for inviting me. Thank you very much. Khuda Hafiz.
Mr. President, our guest of honor, Professor Kadir, is here. You can call him for his address.
Assalamualaikum.
Thank you so much, Professor M.D. Sharfuddin Ahmed, for your valuable and encouraging speech. Now I think Professor M.D. Abdul Kader, he has joined with us. Now I am requesting Professor M.D. Abdul Kader, our guest of honor, Secretary General of OSB, to deliver his speech. Professor M.D. Abdul Kader.
Assalamu alaikum. Can you hear me? Am I audible?
Yes, you are audible.
Yeah.
Yes, sir.
Thank you, sir. Thank you for disturbance. Good noon and good noon, everybody. Greetings from OSB. Greetings from Ophthalmological Society of Bangladesh. Today, I am very much delighted and happy today. It is my great honor today to be here with such a great audience. My deep respect to today's chief guest, my teacher, Professor Syed Mudassir Ali. My heartfelt thanks to my respected teacher, Professor Abha Hussain, today's special guest, and Professor Sharfuddin Ahmed, President of Ophthalmological Society of Bangladesh, and my deep thanks to Dr. Professor Mizanur Rahman, President Bangladesh Glaucoma Society, Secretary General Dr. Salma Parveen, and today's audience. Assalamu alaikum. I congratulate today's organizer, to organize such a great webinar, great conference in a virtual platform. Learning is a continuous process. We are learning, and we are learning from each other. We continuously learning. We learn from each other. So collaboration and communication is a big things in this situation to learn and to learn. So we make collaboration and communication each other. We use this platform in the great way. The virtual conference is a great one. OSB Ophthalmological Society is always with you and also other subspecialty organization. We also will work together. We will be success in our future. I must congratulate today's organizer, Bangladesh Glaucoma Society, and all the members of Bangladesh Glaucoma Society. And I cordially invite you all to 48th Annual National Conference of Ophthalmological Society of Bangladesh, which will also held in virtual platform and on 4th and 5th March 2021. Lastly, I wish great success of this conference, and at last, I must thanks Glaucoma Society to invite me. Allah Hafiz. Assalamu alaikum.
Thank you, Professor M.D. Abdul Qadir, for your valuable advice. Now I am requesting our honorable special guest, Professor Abha Hussain, President-elect APAO, Asia Pacific Academy of Ophthalmology, and advisor, Bangladesh Glaucoma Society. I am requesting, Madam, please give your valuable advice.
Thank you, Mijan. বাংলাদেশ গ্লোকোমা সোসাইটির 11তম জাতীয় বার্ষিক সম্মেলনের উদ্বোধনী অনুষ্ঠানের স্নেহাস্পদ সভাপতি অধ্যাপক মিজানুর রহমান। আজকের অনুষ্ঠানের মূল আকর্ষণ আমাদের প্রধান অতিথি, মাননীয় প্রধানমন্ত্রীর প্রাক্তন অ্যাডভাইজার, বিএমআরসির চেয়ারম্যান, কমিউনিটি ক্লিনিক ট্রাস্টের চেয়ারম্যান, আমাদের সকল চক্ষু বিশেষজ্ঞর অভিভাবক, কর্ণধার, পথ প্রদর্শক, আমার পিতা অধ্যাপক সৈয়দ মুদাসসির আলী। আজকের অনুষ্ঠানের বিশেষ অতিথি অধ্যাপক ডক্টর শরফুদ্দিন আহমেদ, সভাপতি অপথলমোলজিক্যাল সোসাইটি অব বাংলাদেশ, বঙ্গবন্ধু শেখ মুজিব মেডিকেল ইউনিভার্সিটির অপথলমোলজি ডিপার্টমেন্ট চেয়ারম্যান এবং রিজিওনাল সেক্রেটারি এশিয়া প্যাসিফিক একাডেমি অপথলমোলজি। আজকের অনুষ্ঠানের গেস্ট অফ অনার প্রফেসর আব্দুল কাদের, মহাসচিব অপথলমোলজিক্যাল সোসাইটি অব বাংলাদেশ এবং বঙ্গবন্ধু জাতীয় চক্ষু বিজ্ঞান ইনস্টিটিউটের অধ্যাপক কর্নিয়া। এখানে উপস্থিত প্রাক্তন সভাপতিবৃন্দ এই সোসাইটির, প্রফেসর নজরুল ইসলাম, প্রফেসর শেখ মান্নাফ, প্রফেসর জিয়াউল করিম সহ সকল এক্সিকিউটিভ কমিটির মেম্বার, বাংলাদেশের বিভিন্ন জায়গা থেকে এই মিটিংয়ে যারা উপস্থিত আছেন, গ্লোকোমা স্পেশালিস্ট তাদের, এশিয়া প্যাসিফিক গ্লোকোমা সোসাইটির সম্মানিত সকল সদস্য, ইন্ডিয়া গ্লোকোমা সোসাইটির সকল সদস্য এবং সম্মানিত সুধীমণ্ডলী, আমি আপনাদের সকলকে মহান বিজয় দিবসের শুভেচ্ছা ও সালাম জানাচ্ছি। আজকে আমি এই অনুষ্ঠান এবং গ্লোকোমা সোসাইটির মহাসচিব সালমা পারভিনকে অ্যাড্রেস করতে ভুলে গেছি। সালমা পারভিন এখানেই আছে আমাদের মধ্যে, দেখতে পাচ্ছি আমি। আমাদের এই সোসাইটি খুবই শক্তিশালী একটি সোসাইটি। তাদের ন্যাশনাল কনফারেন্সে তারা কতটুকু শক্তিশালী হলে পৃথিবীর অন্যান্য সংগঠনের সাথে এত জোরালো লিঙ্ক আছে যে এশিয়া প্যাসিফিক গ্লোকোমা সোসাইটিকে নিয়ে এসেছে একটা সেশনের সিম্পোজিয়াম তারা করছে। ইন্ডিয়ান গ্লোকোমা সোসাইটিও আলাদা সেশন না পেলেও তারাও অনেকগুলা সেশনে স্পিকার এবং প্যানেলিস্ট হিসেবে আছে। এছাড়া মেক্সিকো, আর্জেন্টিনা, ইউএস এখান থেকেও স্পিকার আছে। কাজেই এই সোসাইটি বরাবরের মতো সব সময় পৃথিবীর অন্যান্য দেশের সাথে যোগাযোগ রেখে এবং গ্লোকোমা ওয়ার্ল্ড কংগ্রেসে প্রতি বছরই তারা বিশাল গ্রুপে জয়েন করে এবং নিজেদের সায়েন্টিফিক প্রোগ্রাম ওখানে গিয়ে করে। প্রফেসর শরফুদ্দিন বলছে যে স্ক্রিনিং অফ গ্লোকোমা অলরেডি এটা হাতে নিয়েছে গ্লোকোমা সোসাইটি, প্রক্রিয়াধীন আছে, হয়তো কিছুদিনের মধ্যেই ওরা কাজ শুরু করবে। আমি কিছুটা জানি বলে কথাটা বলে দিলাম, কারণ এটা আমি এর আগে কোনো এক গ্লোকোমা সোসাইটির কনফারেন্সে আমার একটা আবেদন ছিল যে গ্লোকোমা সোসাইটি অনেক কাজ করে, অনেক একাডেমিক কাজ করে, সায়েন্টিফিক প্রোগ্রাম করে, গ্লোকোমা উইক প্রতি বছর খুব সুন্দরভাবে পালন করে, কিন্তু আমাদের গ্লোকোমার সেই অনেক বছর আগে 78-এর যে ডাটা সেটা আমরা তুলে ধরি। কোথাও গিয়ে বলতে গেলে আমরা সঠিকভাবে বলতে পারি না যে তোমরা একটা করো। তো কাজেই গ্লোকোমা সার্ভে বাংলাদেশ শুরু হবে। আমি খুবই আশাবাদী যে খুব সুন্দরভাবে আমরা এরপর থেকে খুব মাথা উঁচু করে বলতে পারবো বাংলাদেশের গ্লোকোমার এই রেট, গ্লোকোমাতে আক্রান্ত কতজন আছে, গ্লোকোমাতে সাফার করছে কতজন, সবকিছু জানা যাবে। কাজেই আজকের এই অনুষ্ঠানে আমি দেখেছি যে খুব সুন্দরভাবে সকাল 9টা থেকে রাত 9টা পর্যন্ত কার্যক্রম, বৈজ্ঞানিক অধিবেশন এত সুন্দর করে সাজানো আছে। তার মধ্যে একটা সেশন আছে 2টা থেকে 3টা, খুবই মনে হয় ভালো একটা প্রোগ্রাম। জুনিয়র বলবো না, তারা জুনিয়রের চাইতে একটু উপরে উঠে গেছে অবশ্যই, কিন্তু খুব সুন্দর করে ছোট্ট সময়ের মধ্যে এত সুন্দর ভিডিও শো প্রদর্শন করে তারা তাদের কাজ, নিজস্ব যে তারা কাজ করে সেই সার্জারির উপরে ভিডিও প্রোগ্রাম স্পটলাইট তারা নাম দিয়েছে। আমার মনে হয় যে খুব সুন্দর একটা প্রোগ্রাম করতে যাচ্ছে। কিন্তু আমি আরো বলবো যে সিনিয়ররা অবশ্য বেশি ভাবে জড়িত থাকতে হয়, তারা থাকবে, কিন্তু জুনিয়রদের, এদের চাইতেও যারা জুনিয়র তাদেরকে একটু যদি এগিয়ে নিয়ে আসা যায়, যারা গ্লোকোমাতে কাজ করছে, রেসিডেন্সিতে আছে এবং ফেলোশিপ করছে, এদেরকে যদি তুলে আনা যায় এবং সায়েন্টিফিক প্রোগ্রামে উৎসাহিত করা যায়, ইন্সপায়ার করা যায়, তাহলে আমার মনে হয় আরো ভালো কাজ হবে। কারণ আমরা সবসময় দেখে অভ্যস্ত যারা গ্লোকোমা নিয়ে, যারা শিক্ষক তারা তো শিখাচ্ছেন, নিজেদের বৈজ্ঞানিক কার্যক্রম, এক্সপিরিয়েন্স তারা শেয়ার করছে, সবই ঠিক আছে, কিন্তু আমি তারপরেও আমার রিকোয়েস্ট থাকবে আরো যারা জুনিয়র, যারা মাত্র ঢুকছে, যারা কাজ করছে, তাদেরকে যেন খুব সুন্দরভাবে এই সব জায়গায়, এই প্ল্যাটফর্মে জায়গা করে দেওয়া হয়। আমি গ্লোকোমা, আমরা সবাই জানি এখানে আমরা যারা আছি আজকে এই ইনঅগুরাল সেশনে, আমি জানি যে বাংলাদেশেরই শুধু পার্টিসিপেন্ট আছে, সম্ভব হবে না যে একই সময়ে পৃথিবীর অন্যান্য দেশ এই অনুষ্ঠানে যোগদান দেওয়া করা, কিন্তু তারপরেও আমি বলবো যে এই অনুষ্ঠানটা অন্যান্য সময়ের মতো এটা হয়তো ভিডিও শো হিসাবে, যেহেতু আমাদের প্রধান অতিথি আছেন তার বক্তব্য আমরা চাই ভিডিও করা হোক এবং পরবর্তীকালে যারা শুনতে চায় তারা যেন শুনতে পারে, কারণ আমি এখন পার্টিসিপেন্ট দেখতে পাচ্ছি এই মুহূর্তে আছে 28 জন। ভালো ভালো পার্টিসিপেন্ট অবশ্যই আছে, তো এইটা যেন করা হয়। ভিডিও তো অবশ্য হচ্ছে, আর অন্যান্য দিকগুলা খুবই সাফল্যভাবে গ্লোকোমা সোসাইটি করে যাচ্ছে, করবে, ভবিষ্যতেও করবে, কারণ এরা ভীষণ ডেডিকেটলি কাজ করে। ওদের ভবিষ্যতে কাজ করার জন্য এদের যে ব্যাকবোন, যারা পিছন থেকে সহায়তা করে, প্রাক্তন সভাপতি প্রফেসর মান্নাফ, প্রফেসর নজরুল এবং তাদের সাথে অন্যান্য সবাই মিলে একত্রে কাজ করার যে সুযোগ এখানে করে দেয়, তো এই জন্যই এগিয়ে যাচ্ছে। তো আমি আমার আন্তরিক ধন্যবাদ জানাচ্ছি। অনেক সাফল্য মণ্ডিত হবে এই সোসাইটি, পৃথিবীর সব জায়গায় গিয়ে খুব উঁচু মাথা নিয়ে দাঁড়িয়ে অন্যান্যদের সাথে পাশাপাশি একই রকম ভাবে অবশ্যই তাদের এক্সপিরিয়েন্স শেয়ার করবে এবং তারা বাংলাদেশের মাথা অনেক উঁচু করে ঘরে ফিরে আসবে, এই আশা ব্যক্ত করি। এবং সর্বশেষ বলবো, যদিও এটা আমার প্রথম বলারই মনের মধ্যে ছিল, কিন্তু আমি একটা গতিতে চলে গিয়ে কথাটা না বলে, যে বিজয় দিবসে আমার বিনম্র শ্রদ্ধা জানাচ্ছি জাতির জনক বঙ্গবন্ধু শেখ মুজিবুর রহমান সহ সকল শহীদদের প্রতি এবং অন্যান্য আমাদের যারা আত্মাহুতি দিয়েছে এই মুক্তিযুদ্ধের জন্য, সকলকেই আমার প্রাণ ঢালা ভালোবাসা, শুভেচ্ছা এবং বিনম্র শ্রদ্ধা জানিয়ে আপনাদের সকলকে অনেক শুভেচ্ছা জানিয়ে আমি আমার বক্তব্য শেষ করছি।
ধন্যবাদ ম্যাডাম, আপনার সুন্দর এবং সাবলীল এবং অত্যন্ত মূল্যবান বক্তব্য প্রদান করার জন্য, এবং আজকের এই অনুষ্ঠানের পক্ষ থেকে আপনাকে অনেক অনেক ধন্যবাদ জানাচ্ছি ম্যাডাম, আপনার এই এনকারেজিং বক্তব্য দেওয়ার জন্য। নাও we are eagerly waiting for our valuable speech of our chief guest, our teacher, Professor Syed Mudassir Ali sir, who was the former advisor of Honorable Prime Minister of People's Republic of Bangladesh. Now I am requesting Professor Syed Mudassir Ali sir to give his valuable speech, and at the same time I am requesting sir to declare the inaugural ceremony at the end of your valuable speech. Professor Syed Mudassir Ali sir, please.
Please unmute sir, unmute sir.
Is it all right now?
Thank you sir, thank you sir, thank you.
ঠিক
Yes,
আছে,
all right
sir.
sir.
আমাদের ফরেন পার্টিসিপেন্টস আছে নাকি এখন? না শুধু এই মুহূর্তে শুধু বাংলাদেশের?
জি স্যার, ইনঅগ্রেশন সেরেমনি শুধু বাংলাদেশিরাই আছি।
আচ্ছা, তা ঠিক আছে।
এবং শুধু ইসি কমিটির মেম্বার স্যার, অনলি
ঠিক
ইসি
আছে।
মেম্বারস।
আচ্ছা,
থ্যাংক ইউ স্যার।
বিসমিল্লাহির রহমানির রহিম। আমি আমার বক্তব্যের শুরুতেই একজন মুক্তিযোদ্ধা হিসাবে নিজেকে খুব গৌরবান্বিত মনে করছি যে আমার সন্তানেরা আমাকে এখনো মনে রেখেছে, এবং আমি আরো সৌভাগ্যবান যে এখনো জীবিত আছি তাদের সাথে এরকম ভাবে মিলে কথা বলার জন্য। আমরা মুক্তিযুদ্ধে অংশগ্রহণ করি সর্বযুগের সর্বশ্রেষ্ঠ বাঙালি জাতির পিতা বঙ্গবন্ধু শেখ মুজিবুর রহমানের নির্দেশে, এবং তার নাম নেই আমরা যুদ্ধে সবাই যে যেখানে আছি অংশগ্রহণ করি। 6 মে 1971-এ মুজিবনগর সরকারে স্বাস্থ্য বিভাগ গঠিত হয়। আমি সেখানে মাত্র MBBS পাশ করে জয়েন করলেও আমি সেকেন্ড ম্যান হয়ে দাঁড়াই, কারণ টি হোসেন সাহেব প্রথমে ডিজি হেলথ ছিলেন, পরে তিনি সচিব ছিলেন, এবং তার আমি চিফ অ্যাসিস্ট্যান্ট। তার জুতোটা নিতে হলো আমার নিতে হতো, তার অন্য কোনো কাজ করতে হলেও পলিটিক্যাল আমারই, কারণ উনি তো সব পলিটিশিয়ানদের চিনতেন না। সেখান থেকে শুরু করে এখন পর্যন্ত আমার সৌভাগ্য হয়েছে বিভিন্ন স্তরে সবার সাথে দেখা। আর আমি মূল বক্তব্যের আর একটা জিনিস মনে করাতে চাই যে এই মুজিব বর্ষে কিছুদিনের মধ্যেই বঙ্গমাতা শেখ ফজিলাতুন্নিসা মুজিবের নামে আমরা বঙ্গমাতা শেখ ফজিলাতুন্নিসা মুজিব সেল এবং মলিকুলার ল্যাব বাংলাদেশ মেডিকেল রিসার্চ কাউন্সিল বিএমআরসিতে ফর্ম করেছি, যেটা প্রফেসর শরফুদ্দিন জানেন। সেটাতে আমাদের শাহজুল ইসলাম মোল্লা, তিনিও একজন চক্ষু বিশেষজ্ঞ, তিনি লাকিলি ওখানে প্রজেক্ট ডিরেক্টর পরশুদিন জয়েন করেছেন এবং চোখের যদি ডায়াগনস্টিক পয়েন্টে নট ট্রিটমেন্ট এমন কোনো ইকুইপমেন্ট বিশ্বে থাকে যেটা হয়তো ইন্ডিভিজুয়ালি বাংলাদেশ এখনো কেনার অর্থনৈতিকভাবে প্রবলেম আছে, আপনারা শাহজুল ইসলাম মোল্লার সাথে যোগাযোগ করবেন, আমরা কিনতে পারবো, কারণ আমাদের 1600 কোটি টাকা বাজেট আছে। সুতরাং আমরা এইসব রেয়ার জিনিসগুলিও সেল বা মলিকুলার যে কোনো একটা ফর্মুলায় ফেলে এটাকে করতে পারবো। আমি শহীদ মুক্তিযোদ্ধাদের প্রতি শ্রদ্ধা জানাচ্ছি। সেদিন যারা মুক্তিযুদ্ধে অংশগ্রহণ করে ইনজিওর্ড হয়েছেন এবং যারা বীরত্বের সাথে যুদ্ধ করে এখনো আছেন এবং বিগত হয়েছেন, সকলের প্রতি আমি গভীর শ্রদ্ধা জানাচ্ছি। আমরা চক্ষু বিশেষজ্ঞরা আরও একটি বিষয়ে খুব গর্বিত হতে পারি, সেটি হচ্ছে যে এই যে এখন যে করোনা চলছে কোভিড-19, এইটা মূলত প্রথম ডিসকভার করে চায়নার একজন অপথ্যালমোলজিস্ট। দুর্ভাগ্যবশত তিনিও গ্লোকোমা স্পেশালিস্ট ছিলেন। গ্লোকোমা একটি রুগীকে দেখতে গিয়ে তার থেকে তিনি ইনফেক্টেড হন এবং আনফরচুনেটলি মৃত্যুবরণ করেন। সুতরাং সব জায়গায় কিন্তু চক্ষু বিশেষজ্ঞরা, বিশেষ করে আজকে যখন গ্লোকোমার আলাপ করছি, তখন গ্লোকোমার একজনই বিশ্বে নন্দিত ব্যক্তি। আমি অত্যন্ত কৃতজ্ঞ যে এই নজরুলই প্রথম অনেক দিন ধরে এই সাব স্পেশালিস্ট করা, বিশেষ করে গ্লোকোমাটা করার জন্য ওর খুব আগ্রহ প্রকাশ করে। আমি তখন চক্ষু চিকিৎসক সমিতির সভাপতি, সেই সময় এটা কোইন্সিডেন্টালি হয়। তখন নজরুল এবং মান্নাফ আরও অনেকেই ছিল, তবে এই দুইজনই আমার মতে মূল নেতৃত্ব তখন গ্রহণ করে। এই জন্যে সকলকেই আমি খুব সম্মান করি। যেমন এবার সালমা এবং মিজান আমাকে যে কতবার ফোন করেছে, কতবার SMS করেছে এবং যোগাযোগ করছে যাতে আমি থাকি। আমি হলো জাতে মাতাল তালে ঠিক, ওদেরটায় উত্তর দেই আর না দেই থাকবো এটা নিশ্চিত। তারপর আবার নজরুল ভাবছে যদি ইনকেস আমি ভুলে যাই, বয়স টয়স হয়েছে, আবার ও মনে করাই দেয়। তো আসলে যারাই গ্লোকোমা সোসাইটিতে নেতৃত্ব গ্রহণ করে তারা আমার অনেক সন্তান ঠিকই, কিন্তু এই সন্তানগুলি আমার প্রতি যেন একটু বেশি সম্মান করে, এই জন্যে আমি তাদের প্রতি একটু বেশি দুর্বলতা পোষণ করি। হাতের 5টা আঙ্গুল যেমন সমান না, সেই জন্য সবাইকে সমানভাবে দেখি, এটা বললে পারে মিথ্যা কথা বলা হবে। এই জন্যই আমি গ্লোকোমা সোসাইটির, তারা কখনো আমাকে বলে না, তাদেরও কোনো গুরুত্বপূর্ণ অনুষ্ঠানে আমি উপস্থিত থাকিনি এরকম মনে পড়ে না। যখন ডিজিটাল বাংলাদেশ করেন বর্তমান প্রধানমন্ত্রী জননেত্রী শেখ হাসিনা, তখন অনেকেই হাসাহাসি করতেন। আর বিশেষ করে তখন আমি অ্যাডভাইস হিসেবে ক্যাবিনেটে যাওয়ার আগে বলতো যে ডিজিটাল টাইম না অ্যানালগ টাইম। আর আমাদের অনেকের ধারণা ছিল যে ডিজিটাল বাংলাদেশ মানে কিছু কম্পিউটার কিনলে হয়। এই আজকে গ্লোকোমা সোসাইটি থেকে শুরু করে আমরাই জয়েব নিয়ার এই যে ডিজিটাল ফ্যাসিলিটিস নিয়ে এত কুইকলি যে করতে পারছি বিশ্বমানের, এটা কিন্তু বর্তমান প্রধানমন্ত্রীর একটি বিশেষ অবদান। অর্থাৎ তার পিতা বঙ্গবন্ধু দেশ দিয়ে গেছেন, তার কন্যা এই দেশকে এগিয়ে নিয়ে চলছেন এবং সোনার বাংলাদেশ, আমরা কোনো দিকেই কোনো জায়গায় পিছনে নাই। গ্লোকোমা কি অবস্থা আছে, এবং প্রফেসর শরফুদ্দিন বলেছেন যে গ্লোকোমা সোসাইটি এটা নিয়ে তারা অবশ্যই কাজ করছে, কিন্তু আমরা যারা বিশেষ করে চক্ষু বিশেষজ্ঞ তারা তো ভালো করেই জানি, আমাদের বরং পলিসি মেকারদের বোঝাতে হবে যে এইটা গ্লোকোমা সোসাইটিকে, আজকাল অনেক কিছুই কিন্তু অর্থনীতির উপরে নির্ভর করে, তাদের মোটা দাগের যদি অর্থনৈতিক সাহায্য না করা যায় তাহলে তাদের পক্ষে বাংলাদেশে অন্তত কাছাকাছি কি পরিমাণ গ্লোকোমা আছে এইটা বোধহয় বের করা সম্ভব না। সেই জন্যে আমার মনে হয় সেই জিনিসটাও আমাদের মনে রাখতে হবে। সেই জন্য আমি বলবো যে আমাদের সকলের মিলে সম্মিলিত শক্তির ফলে এখানে এখন হয়তো উপস্থিত নাই, মান্নাপের কিছু মনে থাকার কথা দিন মোহাম্মদ ভালো করে জানতো, আর প্রফেসর আবাতো জানতোই। প্রথম আমরা কিন্তু ব্লাইন্ডনেসের একটা সার্ভে করি, আমি তখন এনআইওর ডাইরেক্টর। এটা খুব কঠিন সময় ছিল, এটা যে খুব অবজেক্টিভ তা না, কিন্তু একটি স্টার্টিং হয়েছিল। তো এইভাবেই আমরা আস্তে আস্তে কিন্তু আগাচ্ছি। আমরা এরপরে এই বয়সে এসে আমার সঠিক ইতিহাস বলা দায়িত্ব, সেই জন্য আন্তর্জাতিক সেক্টরে যাতে আমাদের অন 11-এ কি ঘটেছে সেই জন্য রিসেন্টলি আমার একটা বই প্রকাশ করেছি, অন 11 ভিউজ অফ এ উইটনেস, ইন্টারন্যাশনাল মার্কেটের জন্য। প্রফেসর শরফুদ্দিনের নামও সেখানে তার যেটুক প্রাপ্য সম্মান সেইভাবেই দেওয়া আছে, আনিসুর রহমান আঞ্জুম আছে, আজিজ আছে, অনেকেরই নাম সেখানে। কারণ আমি ইতিহাস লেখার সময় কখনোই ইতিহাসের যে যার যেটুক প্রাপ্য সম্মান সেটা, অনেকের সাথে আমার সাংঘাতিক ভালো সম্পর্ক, এখন রাষ্ট্রীয় সর্বোচ্চ পর্যায়ে আছেন, তাদের সম্পর্কেও যে কথা আমি জীবিত অবস্থা এবং তারা জীবিত এবং ক্ষমতায় থাকতে আমি লিখেছি, অনেকে যারা পড়েছেন তারা বলছেন অন্য কেউ সাহস করতো না। তা আমি বললাম যে চিরকালই আমি সত্যের পূজারী এবং খুব স্পষ্টভাবে বলি। যেমন আমার ছাত্ররা জানে যে আমি রাজনৈতিকভাবে সচেতন হলেও আমি বোধহয় একমাত্র রাজনৈতিকভাবে এত এরকমভাবে সম্পৃক্ত যিনি কোনো দলীয় রাজনীতির দলে তিনি কোনো দলীয় প্ল্যাটফর্মের একজন সদস্য নন। অর্থাৎ আমি পানির ভিতর মিশেছি কিন্তু পানি আমাকে স্পর্শ করেনি। সেই জন্যে আমার ছাত্রছাত্রীরা চিরকালই আমার কাছে সকল সময়ে আমার কাছে সম্মান পায়। আজকে আমার যেটা ভালো লাগছে সেটি আমার বলা বোধহয় সবচেয়ে গুরুত্বপূর্ণ, আর 2-1 মিনিটেই শেষ করব। সেটি হচ্ছে যারা এখানে আছে এবং যারা এখানে নাই তারা সকলেই জ্ঞান, বুদ্ধি, প্রজ্ঞা এবং রোগীদের সেবা দেওয়ার ক্ষেত্রে আমার অনেক মাথার অনেক উপর অবস্থান করছে। একজন শিক্ষক হিসাবে, একজন পিতা হিসাবে এর চেয়ে বড় সম্মান নিয়ে এই পৃথিবীতে যাওয়ার সৌভাগ্য অনেকের হয় না, যেটা আমার হচ্ছে। যে প্রেজেন্টেশন আমি অনেক আগে থেকে দেখেছি, যে প্রেজেন্টেশন তারা দিল প্রায় 50 বছরেরও বেশি আগে যখন অপথ্যালমোলজিতে শুরু করেছি, তার থেকেও 30 বছর পরেও আমরা এর কাছাকাছি যে এরকম ভাবে বিজ্ঞান যেতে পারে এটা তো দূরের কথা, চিন্তাও করি নাই। সেটাই দেখলাম আমার সন্তানরা কি সুন্দরভাবে এবং ডেমনস্ট্রেশন দিয়ে এবং পিন পয়েন্ট আবার দেখিয়ে, যদি পিন পয়েন্টে না দেখাতো তাহলে কিন্তু আমি ওইগুলো নিজেও বুঝতে পারতাম না। সুতরাং এই যে সৌভাগ্য, এই যে আমাদের প্রতিটা ক্ষেত্রে সামনে এগিয়ে যাচ্ছে আমার সন্তানেরা, এর চেয়ে একজন পিতা হিসেবে আর কি সৌভাগ্য থাকতে পারে? যেখানে যত পজিশনই পাই না কেন, সন্তানরা যখন পিতার মাথার উপর অবস্থান করে এর চেয়ে বড় সম্মান পৃথিবীতে আর নাই। এবং সেই দিক থেকে আমি সবচেয়ে সৌভাগ্যবান, কারণ আমি শেষ করবো একটি কথা বলে, এটা শুধু তোমাদের জন্য না, তোমাদের মাধ্যমে সকলের কাছে আমি আগেও বলেছি এবং সব জায়গায় রিপিট করি, আমাদের এই পৃথিবীতে আসা তখনই সফল হবে যখন আমরা আমাদের পূর্বপুরুষের জ্ঞান আহরণ করে তার সাথে সামান্য কিছু হলেও যোগ করে পরবর্তী প্রজন্মকে দিয়ে যেতে পারবো। আমার বিশ্বাস আমার প্রতিটি সন্তান সেটা করছে। এমন একটা সময় ছিল যখন কেমিক্যাল ইঞ্জুরি হলে চোখে, যেহেতু তারা মারা গেছে, আল্লাহ বেহেশতে নসিব করুক, চেতন না যে অন্য কেউ আবার জানুক যে ওই কেমিক্যাল ট্রিটমেন্ট কেমন করে। একজন নামকরা প্লাস্টিক সার্জন এমনভাবে করতেন যে অ্যাসিস্ট্যান্টরা যেন না বোঝে। আর এখন আমরা যেটুকু করেছি ওপেন, তার চেয়ে বেশি আমার সন্তানেরা করে। তারা যেটাই করে তারা চায় পরবর্তী তাদের বংশধরদের কাছে যেন এটা থাকে। এইটাই তো সবচেয়ে বড় পাওনা, এটাই তো সবচেয়ে বড় জিম্মা। ব্যাংকে টাকা থাকলে সে টাকা একসময় ব্যাংক থেকে লুট হয়ে চলে যেতে পারে, এমনকি দেশের থেকে লুট হয়ে বিদেশে চলে যেতে পারে, কিন্তু এই যে জ্ঞান তো থেকে যাবে, এই জ্ঞান যুগ যুগ ধরে থাকবে। তাই তোমাদের ভবিষ্যৎ আরো উজ্জ্বল হোক, তোমরা আরো উপরের দিকে থাকো এবং তোমরা দোয়া করো যাতে তোমাদের সাথে আরো কিছুদিন থেকে যেন এরকম বক্তব্য দিতে পারি। কারণ আগের বার যেটা বলেছিলাম এখনো সেটাই বলবো, যে বয়স হয়েছে বুঝবে কিভাবে। আগে তো যখন চুল কাটাতে গেলে বলতো ভাই, পরে বলবে চাচা কোন রং নিবেন, তারপরে এক সময় হচ্ছে মাইক পেলে আর মাইক ছাড়ে না, তখন বোঝা যায় যে না বয়স হয়েছে। সেই কারণের জন্যে আমার যে বয়স হয়েছে বুঝেছি দেখেই এইখানেই শেষ করব। খুদা হাফেজ, জয় বাংলা, জয় বঙ্গবন্ধু, গোলকমা সোসাইটি অজেয় হোক এবং আমার সন্তানেরা দিন দিন আমার চেয়ে আরো উপরের থেকে আরো উপরে অবস্থান করুক। খুদা হাফেজ।
স্যারকে অনেক অনেক ধন্যবাদ স্যারের মূল্যবান বক্তব্য দেওয়ার জন্য। পাশাপাশি আমি স্যারকে অনুরোধ করব, স্যার আপনার মুখ দিয়েই আমাদের এই 11তম ভার্চুয়াল কনফারেন্সের শুভ উদ্বোধনী ঘোষণা করবেন। তারপরে আমাদের ছোট্ট একটা ভিডিও আছে 30 সেকেন্ডের, এটা ফায়ার, এটার মাধ্যমেই আজকের আমাদের এই উদ্বোধনী অনুষ্ঠান আমরা প্রায় শেষের দিকে চলে যাব। স্যার প্লিজ।
আমার মূল বক্তব্য শেষ করেছি, এখন যেটা ফর্মাল ডিউটি, আজকে গ্লোকোমা সমিতির এই সম্মেলনের শুভ উদ্বোধন ঘোষণা করছি।
যাচ্ছে, দেখা যাচ্ছে?
জি যাচ্ছে।
ওকে, ফাইন,
খুব সুন্দর হয়েছে,
ভেরি গুড।
অনেক কাজ করছে এরা বসে।
জি স্যার, অনেক কাজ করছে, মানে ইন অল রেসপেক্ট আমরা ইন্টারন্যাশনাল স্ট্যান্ডার্ড সেটা আবারও প্রমাণিত হলো।
ডেফিনেটলি, মানে একটা সাব স্পেশালিস্টটা এত সুন্দরভাবে করতে পারে, এইটাই তো গৌরবের।
জি জি,
এই জন্য আলাদাভাবে নজরুল, মান্নাফ এদের একটু আলাদা থ্যাঙ্কস দিতে হয় আর কি, দেওয়া উচিত।
হ্যাঁ, ধন্যবাদ স্যার, আপনাকে অনেক অনেক ধন্যবাদ। ডক্টর সালমা, প্লিজ ইউ কন্টিনিউ।
এখন আমি আমাদের সম্মানিত প্রেসিডেন্ট বাংলাদেশ গ্লোকোমা সোসাইটির প্রফেসর মোহাম্মদ মিজানুর রহমান স্যারকে অনুরোধ করছি ফর গিভ হিজ ভোট অফ থ্যাঙ্কস টু অল, এবং এর মাধ্যমেই আমাদের আজকের উদ্বোধনী অনুষ্ঠানের সমাপ্তি টানা হবে। আমি ইনভাইট করছি প্রফেসর মোহাম্মদ মিজানুর রহমান, প্রেসিডেন্ট বাংলাদেশ গ্লোকোমা সোসাইটি।
থ্যাংক ইউ ডক্টর সালমা পারমিন। আমি আমার বক্তব্যের শুরুতেই আমি অত্যন্ত শ্রদ্ধার সাথে 49তম যে বিজয় দিবস, এই বিজয় দিবসের এই মাসে সর্বকালে সর্বশ্রেষ্ঠ বাঙালি জাতির জনক বঙ্গবন্ধুকে শ্রদ্ধার সাথে স্মরণ করছি এবং সেই সাথে মহান মুক্তিযুদ্ধে যারা আত্মত্যাগ করেছেন, যারা জীবন দিয়েছেন, তাদের সকলের প্রতি শ্রদ্ধা রেখে তাদের রুহের মাগফিরাত কামনা করে আজকের এই মহতী অনুষ্ঠানে আপনারা যারা উপস্থিত হয়েছেন তাদেরকে ধন্যবাদ জানানোর জন্য দুই একটি কথা বলবো। We are at the end of the inaugural ceremony and I would like to convey my vote of thanks. First of all, my heartfelt thanks to our honorable chief guest, our teacher, Professor Syed Mudassir Ali Sir, former advisor of Prime Minister, People's Republic of Bangladesh. He has always blessed with us with his presence despite his busy schedule. Next, I must thanks to Professor Abha Hussain, our teacher, and she is the president-elect of APAO. Your presence always impressed us, madam, and your valuable speech enlightened us. Also thanks to our special guest, Professor M.D. Sharfuddin Ahmed, President of OSB, who has always been our inspiration and our leader. My gratitude to Professor M.D. Abdul Kader for being a part of this conference. It has been an absolute honorable to exchange views with the fellow ophthalmologists from around the world. Thanks to all BGS members and all advisors, those who have given their active support in the conference. Thanks to our all panelists, speakers, participants for their contribution. I must offer my thanks to our industrial partners, Aristo Vision, Popular, General Vision, Opsonin, Ibn Sina, and JAS Ophthalmics. A special thanks to Mr. Shubhankar, MNC Event Management for their virtual setup and support. Last but not the least, thanks to Scientific Subcommittee Chairman, Professor M. Nazrul Islam, and Secretary Dr. Salma Parveen, and Dr. Ruhi Mannan, Dr. Ashrafullah Hridoy, Dr. Shahnaz, Dr. Ishtiaq, for their endless effort and dedication for the first virtual day-long conference for Bangladesh Glaucoma Society. We hope you felt welcome among us. We tried our very best, but I offer my humble apology for any mistake. Best wishes and stay safe. Thank you all.
Okay.
Dr. Salma.
So thank you all. This is the end of the inauguration ceremony. Hope you will enjoy the whole conference and with your active participation with so many of very excellent and fruitful scientific program and topics over glaucoma. So thank you all. Thank you very much.
Thank you all.
থ্যাংক ইউ। আমি একটু সবার শেষে বলতে চাই যে অনারেবল চিফ গেস্ট মুদাসসির স্যার, স্পেশাল গেস্ট মাহবা ম্যাডামকে ধন্যবাদ দেই। তাদের দুজনে এত ইমোশনাল একটা বক্তব্য যে আমাদেরকে সত্যি আই বিকাম রিয়েলি ইমোশনাল স্যারদের বক্তব্য শোনার পরে। তো আজকে স্যাররা যেভাবে আমাদের জন্য দোয়া করছেন এবং দোয়া করবেন যাতে করে আমরা এগিয়ে যেতে পারি, আমরাও দোয়া করি আপনারা সুস্থ থাকেন স্যার। সবার জন্য সবাই দোয়া করি। এই করোনার সময়, কোভিডের সময় আমরা যেন সবাই সুস্থ থাকি। আজকে আপনাদের কাছে এই আবেদন করব এবং গ্লোকমা সোসাইটি যেন এইভাবে এগিয়ে যেতে পারে উইথ ইউর ব্লেসিংস স্যার।
ধন্যবাদ সবাইকে।
তাহলে এখন নামাজে যাই।
সর্বদিন ভাই আপনাকে অনেক ধন্যবাদ স্যার, অনেক কষ্ট করে আসছেন স্যার।
স্যার আসসালামু আলাইকুম। আমরা তাহলে এখন একটু নামাজে যাই। থ্যাংক ইউ। আচ্ছা এইটা দিয়ে কি সালমা এই লিংক দিয়ে কি আমরা ঢুকতে পারবো পরেরটায়?
আবার সেম লিংক স্যার।
ওকে ফাইন, থ্যাংক ইউ। থ্যাংক ইউ।
অনেক ধন্যবাদ স্যার, আবার দেখা হবে আপনার সাথে নেক্সট সেশনে।